delighted to be here on a yearly basis. This gig has been going on for 21 years, and it's a highlight of the Dartmouth General experience. There's been wonderful presentations over the years, and this year is certainly going to be no exception. I'd like to ask a question. Has anybody seen the movie My Cousin Vinny? If you have, put your hand up. It was hilarious. Yes. Joe Pesci and Melissa Tomei. Now, if you remember, do you remember the judge?
Yes.
Do you know who he was? He was the Munsters, and his name was Fred Gwynn. And so this little sleazy New York lawyer, ill-prepared, was defending youthful people, and he was presenting to the judge and the court his summary, and he said, "The youths," and Herman Munster looked down at him and, "The youths?" Yeah, Joe Pesci said, yeah, the youths, those young people, those youths. He said, "The youths?" So, where does that go? Today, we have the youths. We've got three of the brightest, innovative surgeons that have joined Dartmouth General Hospital, which is great. And, sorry? And just about this lecture is in memory of a mentor. Jerry recruited me to Dartmouth, and a friend. And each year I tell a story about Jerry, but I'm not going to do that this year. I'm going to leave the Caesar salad out this year.
No.
So I want to thank the foundation and Steve's hard work and taking over the support funding for the lecture. And so I'd like to introduce Steve Hardy as our foundation chairman, and he'll have a few words to say.
Thank you so much, Dr. Davis. Your incredible support, 21 years. This is 21 years of this lecture series. So a round of applause. This is incredible. 21 years. Probably that, 25 years ago or so, you were the youth. You were the youth. Were you? Weren't you? Dr. Burns recruited you as the youth as well. So much has happened. So much is happening in the culture of Dartmouth General Hospitals with innovation. Today we're going to be talking about innovation. This is incredible. It's part of the DNA, part of our culture of the Dartmouth General Hospital is all about innovation, and our donors love innovation. So as a foundation, we are really happy to be sponsoring this event, working with Diane and the family, the Burns family. 21 years, Diane, of your long-term support. So really appreciate you and the family. Round of applause for the Burns family. Dr. Burns is the reason we're here today. He was Dartmouth General Hospital's first chief of surgery at Dartmouth General, a pioneer, starting off what we are so lucky to have today. What has come behind him in terms of what's happening in surgery at Dartmouth General is incredible. And this amazing culture of patient-centric and innovation culture. We'll hear from Patty McDougall today too. Patty's going to talk about the palliative care wing, the new palliative care wing at Dartmouth General. Thanks to the J.W. Murphy Foundation, we are seeing an incredible response from families in terms of how we provide compassionate care at end of life as well. So incredible. So thank you, Patty, for your amazing support. So this is all because of donors, and we are so honored as a foundation to continue this legacy in supporting the Gerald Burns Lecture Series. This year we want to thank Hillrom. So Hillrom has provided an educational grant as well. So thankful to Hillrom for sponsoring this event today. So a round of applause for Hillrom. Nothing here could happen today without the province of Nova Scotia. We're so honored to have Minister Tim Hallman here as well. Mr. Hallman, Minister of the Environment, also head of Treasury Board, and MLA for Dartmouth East. So a round of applause for the province. Thank you. Really appreciate it. I want to thank members of our board as well. We have Anne Janega, our Vice Chair of the Board of the Dartmouth General Hospital Foundation. And thank you for joining us today as well. I also want to say thank you to Margaret Palmater, Director of Innovation at Nova Scotia Health Innovation Hub. Key part of many of these projects we're going to talk about today, with the orthopedic robot, with the work we're doing in pelvic health. You're doing a lot of business cases, and you are great at that, so Margaret. So round of applause. Thank you. So again, today we're going to hear about some amazing innovation. Dr. Jennifer Layton will talk about the orthopedic robot. A year ago, just over a year ago, we, as a foundation, thanks to an early gift from the Dickey family, we decided to help purchase this orthopedic robot, get it into Dr. Layton's hands as quickly as possible. And today you're going to see what impact has resulted based on that decision. Dr. Layton is doing some incredible things, and we're really excited to hear more about the work that Dr. Layton is doing. Thanks to the J&W Murphy Foundation again, we have a new successful palliative care project, which we'll hear about today from Patty. And thanks to donors like Dr. Bob Fredrickson and Focus on Urology, we're going to hear a lot about, from Dr. Duplessis on what's happening in urology. Dr. Duplessis has joined us from MD Anderson in Texas, coming here to back home to Atlantic Canada, here just to work at the Dartmouth General Hospital, so thank you. Again, we'll hear from Dr. Riley Stewart, who's joined us from Harvard in Boston, and coming here back to Dartmouth General as well, so bringing some incredible new ideas and new innovation. So welcome, Riley Stewart, Dr. Stewart as well. Tim, when you build things like 8 new operating rooms, that's what happens. We attract amazing professionals from around the world, so build it and they will come, right? So that's
Bring your grease.
Bring your grease, exactly. I want to send a really special thank you to Carla Purcell. Carla, incredible, round of applause. Carla works year in, year out to make this event happen, this lecture series, and I'm sure Dr. Burns would be very proud of you in continuing legacy. I want to thank the team from the foundation as well, Marianne Couture and Bassam from our Dartmouth General Hospital Foundation, providing support to make this event happen as well. I want to thank Russell Gross as well and the team who's doing the live streaming here. So Russell, round of applause. You're doing amazing work in the Cultural Center. I want to thank Dr. Davis. Thank you for agreeing to being our MC again today. 21 years, incredible. We love your sense of humor, but most of all, we love your passion for patients and your passion for excellence. And we have so many grateful patient stories, grateful patients who come forward after meeting with you. So thank you for all you do. And last but not least, I want to thank Diane Burns. Thank you for your continued support of the Dartmouth General Hospital Foundation. We are so grateful. Thank you. Enjoy the lecture series. Take care.
Good morning, everybody, and thank you for coming. I usually say 3 or 4 words, but this year I've decided it's time to share why we're here. And when Jerry was getting to the end of his journey, the hospital decided to honor him. Well, it was too late for Jerry because he was too sick to come, so he dictated from his bed the words that he wanted to share with the hospital. Anyway, Matthew, we all came down, and Matthew read these words. I'm sorry I can't be with you tonight. I won't read all of it because he was in every department. First, I want to thank my family about that. Next, I wish to extend my warmest thanks to all members of the Department of Surgery, Anesthesia, Medicine, and Radiology for what I consider to be an extraordinary spirit of cooperation. I look back over more than 20 years at the Dartmouth General filled with pride, and I feel honored to have been part of such a wonderful team of people, both as professionals and as friends. Hospital administration was changed drastically over the years since Dartmouth General opened its doors. In spite of this, the hospital has managed to provide a high standard of care with very little reduction in service to everyone in the administration. And he offers my sincere thanks, in particular, wants to extend a special thank you to the patient souls in medical records, because usually on the board at the end of the corridor was a list of doctors who had outstanding charts, and Gerald was always at the top. Next is nursing staff that are statutory second to none. I can say this from working with the staff in the OR and in recovery, emergency, and all the other floors on a professional basis. Unfortunately, recently I was receiving 5 nursing cures, so he goes in for his hospital stay. Anyway, Pod 31 is an excellent cure during my recent stay. And finally, my list of thank yous would not be complete without special recognition to the dietary department. I have made a significant contribution to their budget deficit by the number of dream bars that I have consumed. Thank you so much for touching me in a wall of honor. I truly am honored to be included in this company, and it is something I will always treasure. God bless you all, Gerald. I just thought it was time to share that.
Thank you, Diane, that was great. Those dream bars, they sold them in the cafeteria. As a plebeian, I would go down and I'd get one like a little. Jerry got one this big. And the lady chef at that time took him under his wing, and he got a huge dream bar nearly every day. He didn't like vegetables. He didn't like anything green except Caesar salad. But he did like those dream bars.
Thanks to Katie.
Yes.
Katie.
So our first presentation is from the Department of Orthopedics, and it's a great pleasure to introduce Jennifer Layton. And it's kind of interesting that I don't think you know this. That I recruited the first orthopedic surgeon to the Dartmouth General Hospital, and that was Dr. Bill Cannon. And Bill and I finished our residencies together, and he went to St. John. And we had itinerant surgeons at that time that used to come and do some work and then go back to their other ship across the street. So I called Bill, and we were talking, and Bill was a family doctor. He used to take his horse and hitch it up to the post at Truro. That's the kind of guy he was from Parsbro, very down-to-earth guy. And he said, "George, are you sure there's enough work in Dartmouth for an orthopedic surgeon?" And I started to laugh, because we were flat out, and when he came, the two of us worked together, and we were flat out. And now we have 8, and there's probably going to be 2 more in the offing. So that's how big this department is growing. So one of our leading stars is Jennifer Layton. I knew as a child. She works at Dartmouth General and HI site. She came to us in 2018. She specializes in lower extremity reconstruction with focus on primary and revision hip and knee surgery and some oncology. She was a graduate of Dalhousie Medical School, orthopedic residency training in Calgary, a fellowship in lower extremity reconstruction surgery at Mount Sinai at the University of Toronto. She's energetic, hardworking, and a wonderful colleague. Jennifer.
Energetic sound bigs. We'll see. Well, thank you so much for having me here. I didn't have the pleasure of knowing Dr. Burns, but since being invited to give this talk, it's been so nice to hear all the stories about him, and I feel more affinity knowing he was also a little truant on his dictations, and that makes me feel a little bit better. So I'm going to talk to you a little bit about robotics in joint replacement surgery, and I'm sure lots of you have heard about it through our wonderful ad campaign that's everywhere right now. But so thank you to the foundation for everything they've done to support us, to the Nova Scotia Innovation Hub who have helped make this possible, because I can't write a business plan for the life of me, I have learned. But they've been so instrumental, in the province as well, in supporting us through this. So, you know, Nova Scotia is really becoming a robotics hub and a leader in Canada. I spend a lot of my time actually traveling around and teaching people how to use the robot, teaching why we use this robot. So I'm excited to share with everybody here what we're doing. So most of you probably know me from these pictures plastered around the hospital. But most of the time I'm taking even dorkier pictures outside of work. This is my family, so my husband Andrew and my son Gavin, and that they kind of really pushed me to do what I do. I grew up here in Halifax, and as George was saying, went away to train and was pretty excited to have the opportunity to come back and have my mom help me raise a family here. So, you know, when we talk about innovation, robotics is right at the forefront of this campaign, and we're really excited to be a part of it. And you know, why we get into this is really, you know, to make things better. And so we're very fortunate. You know, I'm a very needy surgeon. I like all of my patients to get better. That's why I choose hip and knee reconstruction. And we're really lucky to have really wonderful outcomes in this area, but they can always be better. And I'm sure everybody in this room, especially our nursing team, has seen people go through complications with this surgery, and we're trying to minimize those. And so what robotics does for us is lets us use a 3D understanding of each patient's anatomy, and predictive modeling helps us kind of plan what should be the most successful surgery for them, and then it actually lets us execute that pretty much perfectly with the robot. And I wish I could say I could execute it perfectly on my own, but I can't. There's human error and cutting jig and instrument error. And so it's been really exciting to use this and kind of see where right and wrong sits. And we're using this to produce research as well with an amazing amount of data that makes these questions that we couldn't answer before. Now we have a chance at answering them because we have so many data points. And before we'd have to plan studies that were nationwide, North America-wide, capturing hundreds of thousands of patients. But with the amount of information we can get from robotics, we can make these much smaller and more feasible. So, well, what is the orthopedic robot? And I was happy to see Stephen was introducing me because he always says the orthopedic robot. And I think everybody thinks this is what they're going to see when they walk into the operating room. And then they're really disappointed when this is what they see. Because it's a little bit underwhelming visually, I think. But there's actually several orthopedic robots out there. And so we chose this one. This is the Stryker Mako Robotics because it has some really special features that I think really put it above the rest, and we'll go through that. I find it's the most exciting in the knee replacement realm, so I'm going to start on that. But just quickly, I wanted to go through, okay, like what is a knee replacement? Because to understand why a robot makes a knee replacement special, you have to kind of understand what the gold standard was prior to robotics that we're moving away from. And so I've used animated pictures for this so that over breakfast it's not too gruesome, because it is fairly physical surgery. But what we do for knee arthritis patients is we cut away the joint surfaces that are worn out, and we replace them with metal and plastic. So I always say to patients, on the end of your thigh bone, you get a fancy cap. On the top of your shin bone, you get a fancy tray, and then a very expensive plastic liner goes in between those so that everything glides smoothly rather than the grinding that they have in there. And so to do that in surgery, first we have to expose the knee. We actually drill a hole into your femur, slide a giant rod up there with this very complicated block that we fiddle with and get it just right, and we use our eyes and our fingers and kind of like make a line, and then we line it up, pin it in place, and we start to resect this kind of slivers of the bone that's worn out, okay? So we'd use one guide to make this cut, then we do some more measurements with a little metallic jig that we line up, we drill some holes, size it to the patient's specific size in surgery, and then use another cutting jig that we pin in place to make further cuts so that our implant fits. And that's what we do on the femur, the end of your thigh bone. Then we go down to the shin bone. Now, there's skin and stuff on top of this. We don't expose this much, but we use this fancy cutting jig that wraps around your ankle. We line it up. Again, we get the fingers out, we close one eye, we line it up with your shin bone. We pin that in place, and then use a little bit of a guide here to measure our 9mm or 2mm resection. And then once we're happy with that, we then make the resection with the saw, okay? And then we put these trial components in. After making all of these cuts, we try it out and see, was I right? Do I like it? Do I have to recut or fiddle with something? Change the type of liner, maybe the type of implant to try and get it to be the perfect feeling that I want it to feel at the end of the case. And so there's a lot of gestalt that goes into this, right? There's a lot of, when we talk to people, like, how do you know it's good? And you're just like, it just feels good in my hands. And that's what we aim for. And so we spend 15 years training to say what feels good in your hands. So we're pretty good at this. This is like 80-85% of people really like their knee replacement. I want it to be higher because I feel like when I leave clinic at the end of the day, it's the 10 or 15% that stick in my head that I'm worrying about at night. It's not the 85% that are happy. So with traditional knee replacement, it's a great surgery. We've been doing it this way for a long time, and we've not really had the ability to move the needle until technology kind of caught up, and technology's there now for us. So we want better for our patients, and our patients expect more too, right? This used to be a surgery that you couldn't do for somebody that was under 65, that wanted to do sports, that wanted to be active. But now patients, we want to keep them active for as long as we can. So this idea of moving the needle, it's small increments, but we have to make big leaps to do that because we've tried all the small leaps. We've got new metals, new plastics, new saws, new jigs, we've done it all. And then when we looked at that sort of satisfaction study stuff that said 80 to 85%, we looked at that in the 90s, we looked at it in the 2000s, we looked at it again in 2019. It's the same every time. So I think we're getting better, but expectations are rising with us. We've got to continue to rise to meet those expectations. And so why turn to robotics for this? Well, I mean, robotics has never really entered an area and left. So the precision, the accuracy is just something that we can't replicate by hand. And we actually have lots of evidence. So in Canada, we don't leap into new technology the way the Americans do, but we're very fortunate to have them as neighbors to our south because we can watch them and see what's happening. Because they've jumped into some new things before and it hasn't gone that well, and we've been really happy to be sitting back. But robotics has been around for about 17 years now, and it's gone through multiple evolutions. And we've seen the evidence. There's over 1 million, they're close to 1.5 million now. That's how fast this is picking up. And we see less pain, less swelling, less narcotic use, which is a big thing for our society right now. Lower revision rates, a small but very meaningful thing because it's a major cost to the patient, to the society, to our system to go through a redo surgery. And we see happier patients. And if you're doing a lot of robotics, it's cost effective too, which a lot of people don't think of when they think of $1 million robot, but it's true. And so when we look at the knee replacement in particular, so what has it done for me? So I've been able to transition to what we call kinematic alignment, which is sometimes a dirty word in orthopedic circles, but what it means is I can really tailor my surgery to a patient's anatomy because I get a 3D picture of what the knee looks like, what the hip looks like before I do surgery. So I can tailor it. It's not a one-size-fits-all cutting jig anymore. Now I can really, in 3D space on the computer, I can rotate the implants around, see how they're going to fit your femur the best. I can really tailor it to your anatomy, and I've seen patient satisfaction scores go up, and the pain and swelling earlier, definitely better. Even my physio, my son here today, so no, my physio in clinic, he's kind of like later career. I tease him that he's a bit curmudgeonly because every time I try something new, he's like, oh, here she goes again. But I've been right, so he says like, wow, like the knees that come in at 2 weeks look like they're 6 weeks. And the knees that come in at 6 weeks look like they're 3 months because it just seems to speed that along, and I don't think that's a bad thing. The other thing that's nice, and some of my OR nurses are here, is that this is what, once we get our jigs and arrays and stuff done, for the actual surgery, this is all the equipment I need. Normally there would be an entire other table there filled with trays of instruments stacked on top of each other. What that means is that it's safer, cleaner, less equipment to take care of overall, and so that's a nice thing for us. So I'm playing with this to see what the best way is to work. Do my best here. Okay. So there's a little video, we're going to keep the noise down. So this is from Stryker, so it's an advertising video, full disclosure. However, I think it's neat because it kind of shows what we do. So here we have a worn out knee, right, that basically needs a knee replacement. And this is what we want to end up with here, is to get this knee replacement on safely. And so I've shown you the traditional ways of doing this, and it works really well. But how do we tailor that to the patient's anatomy without making trial and error part of it? And I don't want to do trial and error in surgery. I want to do trial and error before. So here with the Mako Robotic, like it says, it's a personalized surgical experience because we're getting a CT scan beforehand that gives me a 3D blueprint that I can work from. They show the robot way too much here because I don't think it's a very sexy robot. I think they should like nail it down. But anyways, because I don't have to drill a hole in your femur and put a giant rod up there, it creates a lot less inflammation. It does that because we've already got this blueprint that we can map, okay? So it takes all the pictures from your scan and it turns them into a 3D model of your knee that I can play with in virtual space, okay? So we get this 3D virtual model before we even start. And then I get this planning screen to say, okay, we've sized it. It looks like it's going to be a 4 or a 5. And I get to look and say, okay, I think the 5 looks a little bit better. I can play with it, turn it around, try different things out, and really see what we're going to be dealing with. And it also really helps me address some of the steps that might be hard or easy during surgery as well. Then in surgery, we do this registration where we basically teach the robot where the knee lives in space. And we've got motion trackers on the femur and the shin bone so that as I move the knee around, the robot always knows where it lives. And so this is really different from some of the other robots where we don't have that because we have to teach the robot about the knee in real time. Now I take it through a range of motion, I test the ligaments during surgery, and I can further adapt my plan based on how the patient's ligaments work in real time. Once I make that plan and set it, now we bring in the robotic arm and it does the cuts. I still drive it, but it won't let me go off plane. So if I start to drift, there's kind of what we call haptic feedback. It feels like you're bumping into a wall. So here where they're cutting the shin bone, if I cut too far back, some of the guys at this table know there's a really big artery back there. I can't cut too far back. It will stop. It's like hitting a bumper. And same thing, even if I were to just sort of drift my angle or your hand gets tired and you laze around a little bit, it won't let you go. If you try to push past that, it will stop you. And it takes 900 pounds of force to overcome that, and I've tried and I cannot generate 900 pounds of force. Dr. Smith and I went down to their, where they make the robots down in the States, and aggressively tried to overcome the arm, and we can't do it, which is good that we don't weigh 900 pounds, I guess. But, so we'll go back to the top. Here we go. So this is just to show you, again, a little bit more about what we do, because I wasn't sure if the video was going to work. So this is our slides that I get. So when I start every case, or before I start the case, I go in and review these with our Mako team, and I can take through the different permutations of how I would like the knee balanced and what looks like it's going to be best for the patients, going slice by slice through each one to see where it's going to fit or not fit. This one, for example, can you see my pointer? No. Even little things like in that top right corner there, see how the green sits just a little off that purple line? I'm going to adjust that to make sure it sits just flush, just so. And then all our cuts that we make are going to execute that within 0.5 millimeters, within half a degree. This is our balancing screen, which is really neat because everybody's ligaments work differently. Some of us are loose, some of us are tight, and some people through their arthritis process get even tighter or looser, and we have to address that. We've got different ways to do it, but what's really neat here is I can actually adjust my cuts, so then I don't have to go do ligament repairs, put in fancy plastics, release things that are tight, and tighten up things that are loose. I can actually just adjust it to fit this to the patient right away, and then we end up with the x-ray that we want. It also lets me do really neat things like address old hardware. So this is a lady who broke her tibial plateau, the top of her shin bone, 40 years ago. And she'd been living with this and doing pretty well, but the knee has completely worn out now, and you can see she's sort of falling into that knock-knee position there. She's just so worn out where the break was. But the metal doesn't bother her. The plate is like the fracture healed. She's just got this worn out knee. And so with the robotics, what we can do is look through the CT scan and we can see exactly where those screws are going to be. We can see where my hardware is going to be, where I want to put the metal in. And this is a little bit of a bigger tray because I thought she might be tricky. I want to have, this one has lots of different options I can lock into it as far as the plastics if her ligaments are worn out. And then I can actually pinpoint exactly where those screws will be. So instead of reusing her big long incision before, peeling all the layers back, go and digging that plate out because the bone and tissue always grow over it in 30 or 40 years. So instead of doing that, I just made a little poke in the skin, put the screwdriver in and take the screw out. And I did the same for these top screws. Saved her a big long incision, probably disrupting her ligaments over there and having to repair them. And we can plan this to within the millimeter. So you can see on the far right there, that little green dot is the tip of my tray. So we can plan and see we're just going to miss that screw, and we don't have to go digging further down for it. And so this is somebody, her ligaments were also way out of whack, and I had plans for everything up to a hinged knee replacement, thinking I don't think her ligaments are going to work, so I gotta have all my backups ready. And we were able to put a straightforward first-time primary knee replacement in her. And I can tell you for sure I couldn't have done that manually because I had to do some really kind of weird things for positioning the implants. They're subtle, it looks normal on the x-ray because it's normal for her. But I wouldn't have known that without being able to look at this before. So this is one I just did Tuesday. So I can't tell you how much he loves it yet, but I hope he will. But I can tell you I certainly couldn't get a rod up that curved femur. You see this gentleman had, we call a segmental femur fracture. So he broke in two places, top and bottom of his thigh bone, back in India as a teenager. He was struck by a vehicle and he was treated without any surgery in traction for 6 weeks, which does work. These do heal. It is a miserable process, and you don't tend to end up with a very straight leg afterwards. As you can see here, he's got a number of deformities through the leg. But he's been walking on this with a shortened bowed leg for a long time, and when he came to me with his knee arthritis, we had a long conversation about, do you want me to re-break your femur, straighten your leg, do that first, and get that to heal, and then we can do your knee replacement. He said, the leg's been like this for 50 years. Just, my knee's been sore for 2 years. I want you to take care of the knee. But I can't really do that with our traditional jigs. I just showed you all the measurements we do on that. They're crazy if you try and do them on a bowed leg. And so we did this with the robot to allow us to get it in. The numbers look insane. When I was looking at it on the screen, I had to ignore the numbers and just use, your eyes. But again, we were able to get a pretty routine knee replacement into him that he can get up and walk on right away. He left hospital the next day. In the hip side, so just to switch a little bit of gears, because Stephen would be sad if I didn't mention, we were able to do the first robotic assisted hip replacement in Canada using the technology. It was funny, it was kind of a race, it seemed like, between me and one other surgeon in Ontario, and then it took him like 9 more months to do it after all that. So once the race was over, his motivation kind of dropped, I think, but they're doing them now. But for me, so I use an anterior approach to the hip. So it's what we call a muscle sparing approach. So I don't have to cut any muscles as I make my way into your hip, which is nice because it really helps for early recovery. It's a wonderful surgery. Hip replacement, it's like 90 to 95% satisfaction rate. It's going to be hard to get that any higher because there's a certain number of complications that kind of have to happen in surgery. We wish they didn't, but they do. But what it does is, for me, it lets me cut fluoro out of my practice. So my OR nurse was saying, yes, we don't have to wear lead anymore. We like that because wearing lead in the OR is hard, it's heavy, it's hot. And also, we're still irradiating our heads, our eyeballs, our hands. So there is a higher rate of cancers and cataracts in orthopedic surgeons because of the amount of radiation that we deal with in our practices. And so anything I can do to cut that down for me and my team is a good thing. And then it also lets me accurately get these implants in place. And the more accurate we can be, the better these perform as far as longevity, avoiding complications like fracture and dislocation, things like that. So what's really cool with the hip, it's a little bit different from the knee, because in the knee, I'm still doing dynamic things during surgery. The hip is kind of a set it and forget it. Like I do all my modeling up front and then just execute it during surgery. So this is a patient, I did their hip replacement on the other side. They like that one, no problem with it, thankfully. I used x-ray to get the components where I like it, and we're happy. When we come to Mako, we use their CT scan beforehand. We can really accurately measure what their leg lengths are, what we call their offset, so how far the hip sets from the center of the body, because those really affect how your muscles work. And some people shorten over time as their hip wears out, so we want to try and restore their normal balance that we did. We get this 3D blueprint that I could go through slice by slice and put my femur and my socket side right where I want them. Now I can play with it in 3D. And so you'll see down in the bottom left corner for you these sit-stand numbers. So this is taking the hip through a range of motion, or what's called a stand view. So the hip is coming like this back relative to the pelvis. And we're seeing where, just see this little tiny notch there, that little dab there. That's where the implants are going to start to come into contact. Because with the hip replacement, it's a little bit different from your own hip. And the reason they can dislocate or impinge or cause problems is because eventually, if you get into certain positions, the metal neck hits the metal cup and it can just lever right out. Okay, it's rare that it happens. And it can also be painful when they bump into each other like that. So we don't want our hips to bump into the different parts. So this takes it into extension. I could then take it up into flexion. So we're bringing the hip way up like that to start to see how high we can bring the hip up before we start to run into the components. Here you can see they can bring their thigh bone right up until it touches their pelvic bone. So that's probably good enough for this guy because you can't really go further than that. And then at the end, I get this picture that looks kind of like an x-ray. So I can predict, okay, say, because this is what I have to look at in clinic for the rest of my life, is to say, I have to make sure this x-ray is as perfect as it can be. And then we, in surgery, execute that model. And what's really fun is then your x-rays in the recovery room, there's no surprises. It just looks like what your plan was every time. And that's because the robotic arm lets me accurately place these and measure it during surgery. And so on the hip side, I have to be honest, the hips do so well afterwards. I would say clinically, they're both the same to me. They love being part of the robot, so there's that little like perk in their brains. But I find in the literature, in any case, it says lower dislocation rate, lower impingement rate, or the components bumping into each other, and patients are happier. I don't know if I can make my hip patients happier, but they're pretty happy, and this has been a great tool that I use to help me through that. And there's some non-clinical perks. My son gets to see me on commercials and on buses. He thinks the buses are the coolest part because he's 3. So he thinks that I work with a bus driver, which is like right up here for him. But aside from that, it's been a really wonderful tool for teaching because I can let my trainees make mistakes without making a mistake on a patient. And that's obviously the hardest part about teaching surgeons, is you have to let them do things to learn. But our patients aren't guinea pigs, they're our patients. And so it's a really challenging role to take on, but this is a wonderful tool because they can make decisions and see the cause and effect of the decisions that they're making in 3D without having to make that error around a patient and me go in and fix it afterwards. The other thing that's kind of cool is you can see see those little circuits, those black circles with the silver in the middle of them? Those are what we call the arrays. And so those are the motion capture sensors that we put in so that when I'm moving the limb around in surgery, the camera can see it and follow everything. And all I have to do to turn off the robot is to flick like one finger in front of one of those discs and everything shuts down. So it's super safe. You don't have to yell. You don't have to grab the surgeon that's training with you. Just a quick flick. Like, why did I stop you? What should we change? And so it's really nice from a safety standpoint because I can stand back and give them some rein to learn. Because we're really lucky to have some really great trainees and fellows with us right now, but it still gives me all the control that I need all day in the OR. And it attracts, you're laughing because you need it too. But it's wonderful, it attracts a lot of interest. We've got 3 fellows doing hip and knee replacement. They're shared between myself and the QE2 with Drs. Dunbar and Richardson. One is from Oman, who did his training here at Dalhousie and has decided to stay with us for a year. We've got one from Ireland and one from Australia, and they come because we're using this robotic stuff, because of Dr. Dunbar's leadership in this area. He's a global force to be reckoned with, and this really, brings in a lot of interest in our program. So, and just this week, I had 2 surgeons from Montreal come in to spend the day with me at Dartmouth General to learn about the robotics and see how I use it in practice, because Canadian surgeons want to see Canadian surgeons using it. The Americans, they run 3 rooms, they've got 5 teams, they're doing 15 joints a day. That is not our reality. They want to see how it works in our system, and so we have more and more people coming through to Little Dartmouth General to check this out. And of course the donors have been a real blessing. They've been so engaged. We've been running demonstrations for them, so reach out to Stephen if you want to see those next time we're doing them. And they've been so generous with their time and their dollars to help us really push this, and it's really expanding at a pretty fast rate now. We've done, we're about 250 of these now. Yeah, we're just coming on 250. And then there's other things that we're adding in. So I mentioned the research. That's a big part of it. So with our Mako Robotics, we've got an ongoing longitudinal study that basically all of our knee replacement patients that are willing to participate, we're looking at things like their gait patterns after surgery. This one's called the Knee KG. It's a device that can look specifically at how the knee is working when they're walking to compare it to a normal knee and see how close are we getting to normal. Because one of the problems we've really run into with these joint replacements, as I said, is that they're good, they're very good. So doing research on things that work well is really hard because you have to have giant numbers to show any sort of improvement. And so with things like our gait lab, and we've got these really cool like markerless motion capture cameras, so we don't have to take you to the gait lab and cover you with the little silver balls and spend 2 hours doing that. We actually just have our cameras set up in a hallway. You walk up and down the hallway for 10 minutes and get your gait study done. So that's made a huge difference in our ability to capture patients and start to look at how they move before surgery, how they move after surgery, how does that compare to normal. So this is some really cutting edge stuff that really no one else is looking at in the world to put all this together. And this is something that Dalhousie is leading the way on. And so the donor dollars that came with our robot, we were very fortunate enough to have the Innovation Center put some research dollars in with that price tag, and that's helping to fund this, because that's what we really want to see with robotics. And we have a lot of naysayers in orthopedics in Canada about the robotics thing, that it's like a marketing gimmick. Well, we don't need marketing. We've got a wait list that's 2 years long. Like, we don't need more patients. But that's where we're kind of getting roped into from the companies. And so, but what we really want is that if we as Canadian centers can be researching this, because that's where our drive is, we can really move the ball. And now with AI and machine learning and things like that coming in, that I'm trying my best to understand, but fortunately we work with the computer sciences group that they understand it for real. They can start to take all this amazing information that we're generating and start to use that predictive modeling to say, like, what we're looking for is to say, your knee is different from my knee, right? All of our knee replacements that we've designed have been designed for white men. Shocking, I know. But now we know that there are many different phenotypes, and knees look different across different genders, different races, and different populations, even just based on your nutrition status, where you grew up, things like that. And so we're starting to put things together now to say, with this modeling, to say, if Riley comes in, I'm going to do his knee a little different than someone's going to do my knee someday. And so these are things that that are going to be spitting out, and we're going to be able to look back and say, you know what, Jen, when you do a valgus knee, so a knock knee, they're trickier, they're not as common. And you know what, you're not doing a very good job, because when we look at the rest of the world, everybody else's patients are happier. So why don't you try and do it more like Duncan, because he's doing a really good job, and you should try and use his model. And that's the type of feedback that we need, because we do a lot of these, and it's hard to figure out where your deficiencies are, but this will really provide us that feedback in real time. And then hopefully also move the needle globally as well, because this is being used globally. So it's a very long way of saying, I think robotics are here to stay, so your investment will be well used, so thank you. And there's really good evidence to integrate this into our practice. It's challenging in Canada, but we're working with a lot of other centers now, and the interest is really exploding. So it's a great time to be kind of at the grassroots level of this in Canada, and we really are leading the charge here. So thank you to everyone for your support to allow us to do this. I'm certainly seeing the utility in my practice, and really enjoy helping other people integrate it into theirs. And these future applications are only going to get more interesting, and probably soon we won't even need a real physical robot. It'll all just be like virtual goggles and virtual and instruments that are like smart tools. It's really cool how quickly this is changing, but this is an amazing start, and we're really excited to be part of it. So thank you to everyone. Try to leave some time for questions. We have lots. So does anyone have any questions they want to go through?
In the last slide, you had reference to some initials saying how else you're using it. What were those initials referring to? The very last slide.
Oh, sorry. Unicompartmental partial knee replacement, unicompartmental knee replacement, and total knee replacement, and total hip replacement. A is arthroplasties. Some of my slides are from other talks, and I just kind of put them together. Yeah.
Jennifer, how long does it take?
About an hour.
So easy.
Yeah. It's pretty time neutral now. Like our nursing team's awesome. They've really gotten good at setting it up. That was probably like the hardest thing for the group, was like there's a giant robot in the room now. We've got to work around in different setup aspects. And so what we did when we started was we had a team. So that team came in, they did extra time. They took away from their learning, like on Wednesday mornings, we do Wednesday morning rounds. Everyone does teaching, so the nursing group would do teaching from 7:30 to 8:30, and we start a little bit later on Wednesdays for that. And the surgeons do their rounds. And so we stepped away from those, and they gave us space in the OR, and we brought in the robot, and we would go through all the equipment. We practiced setting it up, and every week we did a little bit more, and then the last week we did like a run through of a case just to take them through. And so they spent that time learning to help us do it. And then what we did was then that nursing team kind of disseminated. So as we kept doing them, every week we'd bring in a couple nurses that hadn't done it before, and the nurses that had would teach it. So it was great. It generated a real kind of team environment, and that's, you know, one of the things that we talk about, what are we trying to do at Dartmouth General, and the thing that always comes up, it came up in my job interviews, is this is like a family hospital, this is a team, we work well together, and so just trying to build on that legacy and keep this as something fun, not stressful. We're doing cool things, so everyone should be proud of it, so we've been really fortunate to have that support to do that.
Do you think that the robotic surgery has the potential to increase the sort of longevity of independence of our seniors population? So elderly people I know, someone in my life who said, oh, I can't be bothered having knee surgery, I'm too old for that. But her independence is greatly affected because she's in so much pain.
Yeah.
So do you see this as being a tool for us to use to increase the longevity of the independence of our seniors?
Absolutely, and one of the things, so I mean, I think my oldest knee replacement I've done is 94. So like, if you're suffering, you're suffering. Some of my 90-year-old patients are much more well and active than my 45-year-old patients sometimes. So, you know, there's age really is a number, and physiology is very different. Robotics does help us look at the 3D planning beforehand to see if there's different challenges based on bone quality and things like that do come up with age. But probably the biggest thing that I see is, I would say two. One is that early recovery is faster, and that's what knee replacements are hard to go through. And I spend most of my consent process telling people how miserable they're going to be for the first 6 weeks. And I still do, because if you weren't that miserable before, you don't know that robotics miserable is less miserable. It's still pretty miserable because it hurts and it's sore, but they get stiff really quickly. So we make you do these exercises. Physio's pushing on you and doing all this stuff. So I tell people, you're not going to like me for the first 6 weeks. But robotics does make that easier. It takes the swelling down, it takes the pain down. They're not using as many narcotics. So I think it eases that process to some degree. Still hard, but not as hard. The bigger piece, I think, is that it decreases that redo surgery rate. And so most knee replacements are lasting around the 15 to 20 year mark. So at 15 years right now, it's about 86% survival of the replacement, not the patient. So we say survival in a different way when we talk about how long our implants last. So they haven't gone back for redo surgery. 86% are still doing pretty well at 15 years, which is pretty good. Hip replacements are like 30 years, so that's what we're aiming for. So with the knee replacements in particular, we're seeing that lower redo surgery rate. Part of it's because the cuts are so precise, we can put these uncemented implants in, and we don't have to worry about the bone quality affecting how the cement's bonding over time. And then part of that is just the precision. If we can put them in better, they last longer. The kinematics are more normal. They don't have a painful knee and we're not sure why. We don't have to redo it for that. So the longer we can make these last, the better it is. Because every time we redo a surgery for these, it's a longer surgery. It has a higher complication rate, higher infection rate, higher bleeding rate that requires blood transfusion, a harder recovery, and a worse outcome. So we don't get better as we redo these. We tend to drop down a functional level when we're going into redo surgery. And so people are often really scared about that. If they're kind of on the fence and they say, well, I'm going to do my knee replacement now, it's going to make things really good, but I don't want to have a redo when I'm 90, so maybe I should try and wait longer. And sometimes that's a good thing, and sometimes that just means that functionally you're getting worse, you're not moving as much, so you may put on weight, you lose muscle, you're more housebound, you lose out on the social things that you like to do, and we all know as humans how important that is for mental and physical health to keep those up. And so I think that moving the needle on the redo surgery rate is so important because that allows people that freedom to just make the decision when it's right for them now and not try and overthink too much what 15 years from now looks like for them, because COVID's proven anything. None of us know what 15 years from now looks like for us. So that's where I think it'll really help, and that's definitely a big motivation here. And the other thing is we're seeing a lot of younger patients coming through for knee replacements, way more than we used to. And so we want to make those as good as we can, lasting as long as they can, because the last thing we want to be doing is redo surgery after redo surgery after redo surgery, because their golden years don't look so golden if you're into that, because it really takes up, it can consume your whole life going through these bad redo surgeries.
Dr. Layton, I know we receive about one grateful patient story every week now. It seems like...
Gosh, I do like 8 or 9 a week. Why aren't they going? Oh my goodness.
Well, my question is, 2 questions. One, how many surgeons are using at Dartmouth General the orthopedic robot?
So there's 3 of us using it, but I'm the only one that's using it like full time now. Like I'm all in on this, and when I first started doing it, I was doing like 1 or 2 cases a day, so it wouldn't disrupt the flow, stress people out, stressing me out. But I do this for all my cases, all of my knees, all of my partial knees. I'm probably up to about 70% of my hips now as well. And then Dr. Duncan Smith is also using it, as well as Dr. Brendan O'Neill has tried it out, still working on it. And then over in Halifax, there's Dr. Michael Dunbar, Dr. Glenn Richardson, Dr. Dave Wilson are all using it over there. Has Bidell done it yet? I don't think so. He talks about it, but anyway, so
you mentioned 250 surgeries already, which
yeah,
is
just shy of it.
So how does that compare with other robots in Hamilton, I think, had one of the UB2 has one. How does it compare that volume?
We're doing the most.
Most in Canada.
Yeah. Yeah, we're right now on the Mako Robotics. So I mentioned there's other robotic systems out there. I would buy it. Well, I work for those other companies too, so I've looked at them all, and I can say, this one's definitely the most advanced. It's been on the market the longest. They've, had the chance to really ramp it up, and using CT base just kind of blows every other robot out of the water. And so for Makos in Canada, we're doing the highest volume right now at Dartmouth General.
Last question.
You're a great plan.
So what percentage would be same-day surgeries? We're getting a lot of grateful patients saying this was a same-day surgery. What percentage
Yeah,
would be?
I'm about probably 60% right now. We were really high. We were like 90% same-day surgery for a long time, mostly because of COVID and bed restrictions and things like that. Dartmouth General has done a great job in helping protect our beds. We're probably the only hospital where they started telling us we had to do more inpatient surgery because we weren't doing enough to keep our beds. And so I think I'm at about, somewhere between a half and 2/3 outpatient surgery right now. They try and, so probably about 60%, I would say. Yeah, and they leave the same day. And then the rest of them, the vast majority, go home the next morning. So we give patients the choice. I don't tell them they have to be an outpatient anymore, whereas in COVID, it was like, if you want your surgery, you gotta go home. But now, some patients just need that comfort level. I find most people that come back for their second one want to do day surgery. Like if I'm doing their right knee, they go through it, they're not sure, it's questionable. So I just say, just stay in hospital, that will make you feel better. And then for the neck, when they come back for their left knee, they're like, no, I can go home, it was fine. So that's a really nice kind of feedback to get that the system works well. And we've had a really great buy-in from our team at Dartmouth General. I would say compared to the QE2, our day surgery pathway is way slicker, and patients notice it. Because I've operated over there as well. And we've had really great teamwork in building that and buy-in in building that. And so that's been great because I just think things get done faster that way. Yeah. Any other questions?
Do you see an application for the MRI?
So with this robot, the short answer is no. It's always going to be CT based because CT is the most accurate for bone morphology. MRI is really good for the soft tissue, so the tendons and ligaments, things like that. In hip and knee replacement, when we're dealing with tendons and ligaments, we're dealing with them on a dynamic basis, so it's not just a present or absent sort of thing. The sports team is really excited about the new MRI because they have to do a lot more visualization of the soft tissues and planning for that. So there'll be a lot more uptake in orthopedics from the sports medicine side. So the ACL tears, meniscal tears, multi-ligament injuries around the knee, shoulder instability and rotator cuff. So that's where the MRI comes in a little bit more. There are a couple companies toying with MRI technology around joint replacements, more so for creating sort of patient-specific cutting guides that they actually 3D print and send them to you. However, because robotics and AI has sort of exploded, it's kind of leapfrogged over that. So that was kind of just getting going, and then these newer other technologies that don't rely on cutting jigs and traditional saws and human error have sort of leapfrogged that. So I don't think we'll see a lot of MRI in the hip and knee replacement space, but in the sports for sure you'll see lots of uptake from my colleagues that are good at scoping. Any other questions?
OR time, has it changed how long you're in there for?
No, it's about an hour for each case.
Like, so if you weren't using a robot, how long would you be in there?
Pretty similar.
Same?
Yeah, I'm pretty time neutral on them for the most part. I would say the hard ones still take longer and the fast ones are still faster. And then on the hip, it was that, like, the knee took me a little while to get time neutral. It's pretty different from what we were doing. And your hands already knew the old way, and you have to learn not to fight the robot is one thing. Like, you have to just admit that the robot's always right because it's your plan that it's executing. So you just have to let it be. But the hip was time neutral almost right away because I wasn't using a C-arm and taking x-ray shots during surgery. So before that, I would stop, take an x-ray, make sure I liked where my cup was, and then I'd put it in, stop, make sure I liked everything on the stem side before I put the final ones in. So now I just check that with the robot, so I'm time neutral, if not maybe a little faster with the robot. Yeah. I keep wanting to be at the point where I can tell people I'm faster with the robot. I'm about the same, so. Yeah. I'll get there. Slow learner.
Jennifer, we'd like to thank you very much for that.
Thank you. Absolutely. Thank you so much.
That was great. So, our second presentation is going to highlight our palliative care unit and what's been happening here. And it's been pretty exciting and very, very, what's the word, helpful to so many of our patients. Patty McDougall has really pioneered her way in palliative care through her nursing career. The first part of her nursing career was she was a medical oncologist in nursing. She worked as a staff nurse in the Cancer Center, 3 years as a clinical nurse educator on the Cancer Center resource team. She's been working in palliative care since 2011. She was part of the in-house consult team at the QE2. Then 5 years in community working in palliative care, covering the Dartmouth and the surrounding areas. She received her CNA certification in hospice palliative care nursing 10 years ago. She's a facilitator with the Palliative Canada's Interprofessional Education Team. She's going to give us a most exciting update on what's going on and her hard work. Patty, welcome.
Good morning. Thank you. It's nice to be here. I've been at Dartmouth General for 4 years, and my first 3, I live streamed the Dr. Burns Memorial Lectures at home, but so my first year that I'm able to be here, I started just prior to the COVID times. The first slide is a shot I took on my cell phone about a year ago, and I was coming off the elevators on the 5th floor, and that's the view that we have when we come off the elevators on the 5th floor. You can actually see the reflection of pot lights from the ceiling on the glass. So we do have some nice vantage points at Dartmouth General. Today we'll speak a bit about palliative care. What is it and why is it important? And I think it is important for all of us as healthcare professionals, but also as citizens and family members. It really should matter to all of us. We'll talk a bit about the Central Zone Palliative Care Team, and I'm a part of that team. We'll talk about the various areas that we cover. And then we'll also talk about what's been happening at Dartmouth General. We had a pilot project that took place between June and September of 2023, and we'll discuss the results of that pilot project and then planning that's going on beyond that. This definition is not concise. It's long, but I actually think there's not a part of it that's not important or that I would eliminate. The World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-limiting conditions. And it does this through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. I've always loved that they added the word impeccable before assessment. I always thought, I always imagined this committee of people coming to a consensus on a definition, and I love that someone thought to add the word impeccable in there. In 2017, the Nova Scotia Health Authority authored a palliative care competency framework, and in that framework, they described palliative care as offering a support system to help patients live as actively as possible until their death, and also offering support system to families, supporting their loved ones with their illness, helping them cope with that illness, but also then helping with grief support following the loss of a loved one. And palliative care is a relatively young medical specialty. It was Cicely Saunders founded the first modern hospice in 1967, and she had trained as a nurse, a social worker, and then as a physician. And she founded St. Christopher's Hospice, and it really was the first hospice that linked expert pain and symptom management with compassionate care, teaching, and clinical research. So really not that long ago in 1967. And then palliative care really came to Canada 50 years ago and actually came to North America. So it was started in Montreal by Dr. Belfour Mount, who was a surgical oncologist and urologist. And he had gone to London to study with Cicely Saunders. And these are her words: "You matter because you are, and you matter until the end of your life. We will do all that we can, not only to help you die peacefully, but also to live until you die." There's been many advantages associated with palliative care. Palliative care services have demonstrated to improve patient satisfaction with care, improve symptom control and quality of life for patients, reduce healthcare utilization, and lengthen survival. And in that list, the surprising bullet for me was lengthen survival, and I see some expressions of people sitting in the room, and we'll come back to that, but that was a surprise for me when I first started working in palliative care. It's been shown to be cost-effective, and so it can create efficiencies a variety of ways by reducing the overall length of stay, helping to move patients from hospital to home or hospital to hospice, which all have lower cost per day than acute care. It can reduce the number of admissions to intensive care units, reduce unnecessary diagnostic testing, reducing inappropriate disease-targeting interventions. So not long before I started in palliative care, I started in 2011. In 2010, there was a study that was published in the New England Journal of Medicine titled "Early Palliative Care for Patients with Metastatic Non-Small Cell Lung Cancer." And it came out of Massachusetts General. All the patients in the study had stage 4 lung cancer. So they all had incurable disease, and they were receiving oncologic treatment, but it all was for controlling disease, not for cure. And they randomized the patients in the study to two groups, one that received standard oncology care, and the second that received standard oncology care plus early palliative care, consult, and follow-up throughout the course of their illness. And the findings were interesting. I think not surprisingly, we saw that quality of life scores were better, and it would almost be disappointing, to be honest, if we didn't see that, then I think we're not being very effective as palliative care teams. So quality of life scores were improved. There were statistically lower rates of anxiety and depression. But the real surprising finding is that the patients in the second group, the patients with palliative care and oncology follow-up, lived longer. So the average survival for the patients in the first group was 8.6 months, and it was 11.1 months for the patients in the second group. It's only months longer, but what's I think most important to remember is that it also, those patients had better quality of life. So not only were they living longer, but they were living with less symptom burden. So it was a really interesting study that was done, and it's been replicated in other disease sites and in other illnesses. So when we think about that, we think then, gosh, why doesn't palliative care see everybody living with chronic illness early on in their diagnosis? And And I think really, when we imagine the number of patients, the number of people in our communities living with life-limiting illness, it's really so large. So people living with metastatic cancer, people with congestive heart failure, COPD, with end-stage renal disease, with many chronic illnesses that we know are progressive over time and are not curable. I think for all of those problems, there can be a benefit to a palliative approach, but it's certainly not scalable for palliative care to be involved early on in all of that patient population. So it really speaks to the fact that palliative care is really everyone's business, that we all have to develop some skill at a palliative approach, that all members of the health team have to be part of providing excellent palliative care. In this slide, it shows that as the level of complexity for the patient increases, the level of complex symptoms increase, there's an increased need for specialized palliative care teams. Much of the palliative approach to care is done by generalist teams who know the patient the best. They know the patient the most well. So we'll talk a bit about the team within the central zone. And first off, it's very large. We cover a large geographic area, so that those purple areas are the areas that are covered by our central zone palliative care team. So we cover a lot of territory. On the furthest right is the Tri-Facilities area where Sheet Harbor, Middle Musquodoboit, and Twin Oaks are. There's a nurse who works in that area and would see patients at all those 3 hospitals. And then she also sees patients at home. And on the furthest left is West Hants. So those are the 2 areas that are the most rural in the areas that we cover. That nurse also sees inpatient consults as well as home consults. And then we cover everything that's in between. The population numbers that are listed there are actually from 2018. And as we know, there's been a lot of population growth since that time. So at that point, the population in the central zone was 409,000, and it had gone up to 480,000 by 2022, so I don't know what it is now, but it's certainly been on the rise. So we know population is increasing in the areas that we're covering, but also patients we are living longer, and people are living with more comorbidities. So we know there's increased need over time for patients who would benefit from a palliative approach. Within the palliative care service, we have a variety of teams. So our community team sees patients whether they're at home or we see them in a clinic, and where we see them really depends on patient function. Then we have an inpatient palliative care unit on 7A of the VG. We have an in-house consult team as part of the QE2 that covers the VG and the HI. And then we have a team that sees patients in Windsor, Hants, and Dartmouth General. And I'm based full-time in Dartmouth General, but the physician is shared between those 3 hospitals. In terms of our community teams, we divide our patients up based on geography. So when we receive consults from family doctors, from other specialists, from the emergency room, we look at the address and we see where they live, and we actually divide the patients up based on where their municipal polling district is. So we divide them up. Nurses in the community cover certain polling districts. And then we're further, then we also are part of 3 separate teams. So each team has one palliative care physician associated with the team, and then team 1 and 2, which are the largest, have 3 nurses that work on those teams, and team 3 is a bit smaller geographically and also in terms of population, and there's 2 nurses and 1 physician on that team. Team 1 includes Dartmouth. So that team would, it also has a little smidgen of the peninsula of Halifax, but it travels out as far as Chesapeake and Gates Brook. beyond that is picked up by the nurse in Twin Oaks. And then we would go through the Eastern Passage. On Team 2, we actually go as far as Enfield, and then in the other direction to Mount Uniacke, and then through to St. Margaret's Bay. And then the rest of HRM is covered by the third team. The numbers of referrals are there on the left, and so Team 1 in 2023, from November to November, had 309 referrals. Team 2 had 334. Team 3, 236. It was a total of 879 referrals last year that the community team received. So certainly a large volume. The day that data was pulled for me by my manager, Eric Newson, at that particular time I asked him to take a snapshot of, to look at, he looked at how many people the community team were currently following, and at that time they had 191 community patients, 59 that they were following in clinic, but 132 people that they were following in their homes. So it's really quite large. Many patients would prefer to stay at home and would prefer to stay at home as long as possible. And for some patients, that can mean staying home right through to end of life. And certainly when that's possible and involves a real team approach, so we work closely with primary care, with continuing care, so with home supports and with VON. And there's also a service in Nova Scotia called the EHS Special Patient Program. So when patients are planning to stay at home, and particularly if there's a comfort focus in their care, we can register them through a program through EHS that allows the paramedics to know a bit about medical history, and maybe most importantly, know about the patient's goals of care and wishes and preferences for care. So it lets the paramedics know, is it a patient who wants to try to avoid hospital? Do they want to stay home for end of life? And then they can sometimes help to manage symptoms at home and not transport the patient to hospital. They have access to a medical director, and so they can call through to that medical director if there's new symptom issues, and they do carry palliative medications with them. So that's been a really helpful program, and actually it started in Nova Scotia and PEI, but it's then been replicated in other provinces since then. We have a bereavement coordinator as part of our program, and so she does a lot of work with other teams helping to provide competence around grief literacy, but she also sees family members, and she sees both individually, but she runs some groups. She has a group session that runs at Alderney Landing. So if you were to Google Central Zone Bereavement Program, you'd find some information about her work. There's also bereavement support available through Hospice Halifax, and you don't have to have had a loved one at hospice to access those services, so they're available to anybody in Nova Scotia, even if you've not had an association with hospice. So at all of our hospitals in Central Zone, palliative care happens, and our palliative care team can be involved just by physicians placing a consult. It doesn't show up very well, but the two yellow dots are really where we have more specialized palliative teams right now, and so we currently have a specialized palliative care unit at the BG. Those patients are actually admitted to the palliative care service. So the palliative care physician is the attending physician caring for those patients. And then around the patient, there's some services like music therapy, extra psychosocial supports that are available at the VG. And the nurses on that unit all have special training and experience in providing palliative care. And the other yellow dot is hospice. And so certainly hospice is a 10-bed facility in the south end of Halifax, and we're very lucky to have it. They provide excellent end-of-life care for patients and families who maybe can't be home for end of life, but don't necessarily need to be in the hospital. And so that started in 2019, and at the time when it opened, They estimated for our population then, which probably was in the planning phases, 2016, 2017, they estimated we should have 30 hospice beds for our population at that time. They were able to get off the ground with 10, and typically hospices are smaller to kind of keep that more home-like feeling. But at the time, it was estimated we could have 3 to serve the population. So we'll talk a bit about Dartmouth General, and I've got a picture of Angela McFadden there that folks who were here before my time, before 2019, will remember Angela. She was the first consult nurse at Dartmouth General and really got that program developed and started. So she did a lot of work to advance palliative care in more than 20 years at Dartmouth General. The palliative consult nurse, so I work at Dartmouth General Monday to Friday. The palliative medicine physician visits Dartmouth General once or twice a week, and lately it's been twice. We had a period of about a year where we were short a couple of physicians because of a couple of leaves of absence, but those are full right now, and so they're currently visiting twice a week. They're available anytime, though, to me over the phone, so we certainly talk very regularly, and they provide a lot of phone support to me and to other physicians at Dartmouth General on the days that they're not there. So we see patients all over the hospital. So historically at Dartmouth General, our palliative patients are dispersed throughout the hospital on whichever, typically on the hospitalist medicine teams, but not uncommonly on surgery either. Many of our patients having surgery or have severe frailty, or also may come in with underlying comorbidities like metastatic cancer. And so it's certainly not uncommon that I be seeing patients there also. We also provide a link from hospital to the community team. So sometimes the initial consult to palliative care happens while that person is at Dartmouth General, but the patient may want to transition to home and have either a period of time at home or an end of life at home, and then I link that patient to the team in the community. I follow about 130 patients a year who have end of life in Dartmouth General. The number varies a little bit, but last year it was around 130 patients. So I see more consults than that every year. Some patients we might see initially and may not need to follow, or we see patients, as I mentioned, who go home. But there's 130 people that I follow right through to end of life. And so a really exciting thing happened late 2022 where we heard that when a big donation was happening from the J&W Murphy Foundation, that they specifically earmarked that they wanted a portion of it to be used to help improve palliative care at Dartmouth General. And the J&W Murphy Foundation have been very devoted and interested in palliative care for some time. And in 2019, they also made a very large transformative donation, really provincially, to affect palliative care. They made a significant contribution to getting Hospice Halifax operational, and then they also fund a palliative care research endowment to help improve palliative care kind of going forward. So that's been a special area of interest for them, and I think it's been an interest of theirs because of their own personal experiences that they've had, both positive and also when they've seen gaps in our system, so that things that they've experienced within their family that have moved them to make a difference in this way. So there can be a lot of challenges providing end-of-life care in an acute setting, and any of us that are working at Dartmouth General have certainly experienced many of these challenges. We have a real problem with site overcrowding. So our hospital runs at more than 100% capacity all the time over the last number of years. Our family rooms have patients admitted to them. Our hallways have patients admitted to them. Our hospital is crowded. It can be busy and noisy. So the physical environment is not always calm and peaceful and home-like. And also, And I think even more so since the pandemic, there's been a lot of turnover in staff in the inpatient areas. And so there's also a variation in skill levels and experience in palliative care in a way that I think there really wasn't historically. I see quite a change in that way. In the last 4 or 5 years, there's quite a difference. And I think we see that in palliative care, but I think that's probably true in all areas of medicine. There's just been that real turnover in staff. Many of the units that just don't have that same backbone of mentorship and experience that existed at one time. So when we heard about the possibility to really make a difference for patients at Dartmouth General in terms of how we deliver palliative care, we struck a committee to look at how we do that. And we talked about various options, and early on, we all agreed that it would be good to make an investment in the emergency department to try to create a space that when people come in after having an acute change, end-of-life care could be provided in an area that helps meet the patient's needs and the family's needs. So there was consensus amongst our committee, but also with hospital administration, that was a reasonable thing to do. And then we had lots of talk about what else to do. And our committee strongly felt that cohorting some patients in an area could really make a difference. We felt there were some benefits that would happen with that approach, that we'd have more control of the physical environment, that not only would we have a nice room, but the environment outside the room could be improved also, that it could be calmer, quieter, that we could have some other amenities and work on getting family rooms, etc. So when we took that to the management group and also to administration, there was real concern because of the capacity issues that we face at Dartmouth General. And so the initial answer was no. They didn't feel it's something we could move forward with. And at the time, our committee strongly felt that it was a sizable donation the family was going to make, and we felt that we wanted to be good stewards of the money, but we also wanted to make sure we really made a difference to patients and families. And the foundation was really supportive and said, the family are really looking for something that's really going to change the way we're delivering care. And so we proposed doing a pilot project. And so as a part of that project, what we did is we didn't invest any money into infrastructure changes, but we, for a period of time, from June 15th to September 18th, we cohorted 5 beds on 5 West. It's one of our newer units in the hospital where the rooms are larger. There was one wing where it's all private rooms and lots of light. There was enough space that families could room in. And over that period of time, we wanted to look at, does it negatively impact patient access and flow? Does it improve patients' experience, the experience of patients and families? Does it impact the perception of healthcare teams providing end-of-life care? Does it make a difference to the staff doing the work? So we created a cohort on 5 West. It didn't cost us any money. We didn't make any changes to the rooms at that point. There were some TVs actually installed, a donation that happened that provided TVs for the rooms. But outside of that, it was cost neutral. We didn't spend any money at that point. So we utilized various methods to gather some data during that time. We used a bed tracking tool to measure how often the beds were used for patients at end of life. We had the patient flow managers who do a lot of shifting and juggling to get patients moved to the hospital, get patients from emergency up into rooms, get patients who are booked for surgery into beds. That patient flow manager was tracking whether there was negative impacts to access and flow at any point. And we also did some surveys with patients and families to track their experience. So we did some surveys prior to the pilot starting and then did surveys during the pilot. We also did a site-wide survey with frontline staff. And I actually don't know how many staff were surveyed, but it was done by Rachel Nalapa and Becky Croft, where they went around with a smartphone and collected and did electronic surveying of frontline staff experience. Prior to the pilot, the data is site-wide, and then we collected data from the staff on 5 West at the completion of the pilot project. So the first question we asked staff were, how often can you provide sufficient end-of-life care? And the two pies look very different. So in the first pie, pre-pilot, so again, the whole site, 59, sorry, my old eyes, I'm not part of the youth at the table. 59% of people felt that they were often able to provide sufficient end-of-life care. 34 said always. But concerning is that 6% said they never felt that they were able to provide sufficient end-of-life care, and 1% of people felt they always were providing the end-of-life care that they felt was adequate or sufficient. The next question we asked staff is, how strongly do you feel patients and families have a good experience during end-of-life? So again, the two pies look really different. So pre-pilot, 61% of staff felt strongly that patients and families were having a good experience. 36 were sometimes, 2% felt rarely, and only 1% said always. And then this next pie is really quite amazingly different, where on 5 West during that period, largely people felt they were providing, the end-of-life care that was of good quality to the patients and families they were caring for. So just really different. We also looked at our bed fill rates. So we had 5 beds, 62% of the time they were filled with appropriate palliative care patients. But it was interesting when you actually look at the last month of the pilot project, 100% of the time they were full with a wait list. So I actually think some of that data was that as people were just getting to know about the beds being available and learning about who was appropriate. So our fill rates were actually a lot higher at the end of the three month period. We also had asked bed managers to track how often it negatively impacted flow, and the answer was 0. We didn't once have a report of it impacting flow negatively. And to be honest, I wasn't shocked by that. In most cases, those patients already exist in our hospital, so they were there. We're moving them and hopefully helping to improve the experience for patients. But the patients were there. One thing that we have been able to do since the pilot project started, though, that had been a problem for a long time and difficult for us to do, when patients are followed in the community team by the palliative care team, it's not uncommon that patients in Dartmouth do not want to go to Halifax for their end of life. So it's really common that when I was seeing patients in their homes, they would say, I want to stay home as long as possible. Some of those patients would say, I want to stay home through the very end. But then there's another subset of patients would say, when I can't stay home, I want to go to Dartmouth General. And that population was difficult for us to serve. We didn't have a way to directly admit those patients to hospital. What had been happening over the last number of years is that if a patient had a strong preference to go to Dartmouth General for end of life, because the emergency department already had, at that point, maybe 10 to 12, and sometimes it's more like 20 to 30 patients admitted in that department. If we were to call the bed flow manager to say, is there an available bed? The answer is no, there actually isn't. There's a number of people waiting. So what we would end up doing at that point was sending that patient to emergency. If they were refusing admission, and I don't mean refusing in a punitive way, but they did not want to go directly to the VG hospital. For them, it was important to stay in Dartmouth. There was many people that actually chose to go to emergency rather than accepted direct admission to the VG. And so we had met separately as a team to talk about how we might be able to do that differently. And so it was really a side of this project, but we did come up with a process that if the community team identified an appropriate patient, they would call the bed flow manager and hopefully divert that patient from going to the emergency, but instead go directly to a bed for end-of-life care and be accepted by a hospitalist within Dartmouth General. I actually think without some of the traction and cultural change that happened with this project, I don't know that we would have been able to get that to happen. So I think as of now, as of this week, I think we've had 9 patients directly admitted from home. We've not always, the very first time that call has come in, we've not always had the empty bed that we can put someone in it that day, but often if we've got some time, we can plan within a day or two to get the person into the next available bed. And so actually that's been incredibly rewarding to be part of. Certainly sending patients at end of life who are not interested in investigations to the emergency department feels awful. It's not good for patients and families, but it's also not good for our system. So avoiding that has been honestly one of the most rewarding parts of this project for me. In terms of the patient and family experience, first off, I want to say it's certainly not to say that patients aren't receiving a lot of good quality palliative care and other units in the hospital, but consistently what patients and families did comment on, even if they overall were very satisfied with their care, they almost always mentioned the busyness of the nurses. So that was written on it was written on every study, every survey rather, that the pre-pilot did. So even in patients who are very satisfied, they all mentioned how busy the staff were. They mentioned wait times for medications, particularly pain medications, wandering patients into their rooms. Some patients mentioned being scared at times because they were in bed, couldn't get out of bed, and there's patients wandering in their rooms. So we know that there are a lot of patients waiting long-term care in our hospitals, and so sometimes wandering is a problem that happens on our units. But you can imagine if you were dealing with, with facing the end of your life and you're bedbound, so that certainly could be scary and not the experience you'd want for your family. And many of the surveys also mentioned that they felt that they needed more and clearer communication. What was interesting, or most interesting to me in the post-pilot, is not one of the surveys mentioned the busyness of staff. I think that the nurses were probably as busy. I think what's different is that maybe the way that they're able to enter the room, there's something about having those rooms dedicated and feeling like the patient's in the right place and the staff are really kind of empowered that this is just as important as the acute care we're providing, and there's something about, I think, that shift that happens, and people, the patients and families experienced it differently. And families certainly have expressed appreciation for the environment, and that was without us spending any money. The rooms are larger. Often families can room in. On a couple of our units on 3 East, which is well represented, and 4 East, those private rooms and those units are very dark. The windows are covered over. So many of our private rooms that our patients would go into toward end of life aren't ideal. So in terms of moving forward, so first off to say that, I guess to back up, that when we presented that data to the administration, they felt that it's something that could go forward and become permanent. So that's the really exciting news, is that we did receive news back in September that this is something we could work on developing further. So we are planning the physical space on 5 West, so there'll be some, those rooms are already quite nice, but there'll be some renovations within the rooms to make them a bit more homey and welcoming to families. They'll all be equipped with a bed, with a sofa that pulls it into a bed, and with Lazy Boy chair, not Lazy Boy brand, but a recliner chair. There'll be a kitchenette outside of the rooms for patients and families. We're going to bring back the family room. So right now in Dartmouth General, within the whole hospital, we don't have any family rooms that are operating as family rooms, and we really felt strongly that if we're providing end-of-life care to patients who can't go home for end-of-life, that we need a space for families to be able to spend some quiet time. Sometimes you need to have private conversations outside the room. People often want to get that break, but they don't want to go too far. And really that's a problem for us right now at Dartmouth General. We're working on education for the staff on that unit. So the clinical nurse educator and resource nurses are working on ongoing palliative care education. But then we're also looking at providing education to staff within the hospital more broadly. So we know that there's interest in lots of areas within the hospital in palliative care, and we're excited and glad for that. So we are hoping this year to provide LEAP education to Dartmouth General staff and physicians who are interested. We're looking at training and incorporating volunteer services with our patients on the 5th floor, our palliative patients on the 5th floor. Right now at the VG and hospice, volunteers play a really big role in the delivery of care. So they help with a lot of the care, they help with a lot of the caring and care that doesn't need to be done by health professionals. So our volunteer services coordinator at Dartmouth General is partnering with the volunteer coordinator that covers 7A. Our Central Zone Health Service Manager has been really supportive and is helping to support our Health Service Manager, Shelley Hayes, who is on that unit. And so he's been very excited about what's happening, and I'll be quite honest, as he hears about development happening in Dartmouth General in the coming years, as we look at expansion, he's really hoping that perhaps this could be a full capital P palliative care unit with dedicated palliative medicine resources. So we're hoping that maybe this could be the beginning of building something even bigger as our hospital grows and our communities grow. And so then we're also looking too at the team on 5 West providing that care. Right now, they're staff that were hired as part of a hospitalist medicine unit who didn't necessarily choose to go to a palliative care unit when they applied, but the health services manager is going to include that there's a component of palliative care in the job posting. It will be part of interviews, so that we're choosing patients with an interest, staff with an interest in palliative care as that team is being built, and we're looking at the model of care and the interdisciplinary team around those patients. So I wanted to close with something I read as I was preparing for this presentation. I happened upon these Irish standards of end-of-life care in hospitals, which I plan to go back to. They were really interesting. I noticed when Nova Scotia Health developed their competency framework, they actually had referenced these standards. And so in reading them, I really liked this quote. Hospitals will continue to be major providers of end-of-life care for the foreseeable future, despite or perhaps because of the significant advances in medicine. Generally, end-of-life care is not fully reflected in hospital cultures, systems, or structures. It is frequently not seen as a core activity of hospitals, and it's not normally included in service plans. The lack of comprehensive approach to the end-of-life care gives rise to concern that we may not be guaranteed a good quality of life in our declining years or a good death at the end. So I think as advances are happening in public health and medicine and we're living longer, I think there's a clear need to look at advocating for more palliative care resources, but also I think that there will always be a role for excellent palliative care within hospitals. So we can try to get more community resources and try to work on more hospice resources, but I still think it's important that we're providing good quality end-of-life care in hospital. So thank you very much. And are there any questions that folks have?
I'd just like to say congratulations on achieving the permanent status
Thank
project.
you.
You kind of downplayed that, but from my point of view, that's a very big deal. And especially in light of this prediction, it seems to be an important direction for our hospitals. Thanks to you and your team.
No, thank you. It's been really exciting to be part of the team. There's been a real enthusiasm, and it's actually when work can feel difficult at times, it's been the thing that's lifted me up lately. Certainly being able to get patients in directly from home to a bed has been huge, and I know our numbers are still relatively small, 9. But when you think about the difference that makes to 9 families, it's really significant. I think one of the things that's helped it be successful is that we do have Brenna Vandhall as part of our team. So Brenna is on the committee that's looked at how we do this work, but she's also the medical director at hospice. And so when we started too with the pilot, Dr. McLennan, the chief hospitalist, actually positioned Brenna on 5 West so that she, all of the weeks that she works, every second week that she would be on, she's able to provide mentorship and informal teaching to the staff, and I think that's been really huge. Having the concentrated beds also positions me on 5 West a bit more. I'm still other places through the hospital, but it allows to, hopefully, for some more mentorship and support from me. But it has been really exciting. Thank you.
I have more just a comment than a question, but I think you probably also didn't emphasize how much good we do for our surgical patients, because we do have a lot of very frail patients, and a lot of the surgeries that we do in orthopedics on an after-hours basis are kind of palliative surgeries as well, right? They're for symptom control. Yeah. And I think what you bring to the table is the time and the presence that we maybe don't have on the floor, and it does make a really big difference to that end-of-life care in the hospital. And I think it's a credit to you that I see less and less. Like sometimes we just get that knee-jerk, like when we're asking palliative care to see is like we're killing somebody for, but it's so much more than that. And I really don't see that anymore. Over the last few years, I noticed a real difference that when we say we're getting palliative care involved, everyone goes, oh, thank goodness. Like, it's not up to orthopedics anymore. We need an expert in here. And so, whereas before it was like, well, what do you mean palliative care? Because I think we're seeing such a change in that approach. So just thank you for that.
I thank you for your leadership on this project. It's incredible to watch you work and see this come to life. So thank you. Talk about the emergency department, having a palliative care room actually in the emergency department. Is that a first, or is that common?
That is a good question, and actually one I don't know the answer to, Steve. I think that, yeah, it's a very good question. I don't know if other areas have an area.
Makes sense, for sure.
But, so we do know that while we would never plan for end of life in an emergency department, things happen in unplanned ways. And so the reason that we wanted to renovate a room there is that if someone comes in and they're declining quickly and there isn't going to be time to transition to an inpatient bed, we wanted to have a appropriate setting for the patient and family to be for the end of life, and it does make sense. That room will get utilized for other things when we don't have a patient experiencing end of life, so it's not like it will stay empty. But I think that it is really important. And early on, everyone agreed that that made sense to do. And I think that really the administration has been very supportive. It's just that there are so many challenges and so many competing interests, so it is difficult and challenging. So I certainly don't want to infer that we didn't have support. It's just that it's difficult. Yeah.
What's the age group of your patients in palliative care is like?
Yeah, it's interesting. I do find at Dartmouth General, in general, the patient age is a bit older. So I think it is a little bit older and a bit more frail. So I previously covered the BG, and because of those oncology units, it almost pre-selects for a younger patient population. So I think our patient population in general is a bit older. One of the first patients we had in one of those beds, though, was in his early 20s, so it's a real range. So we certainly have had we see young people on all of our units living with metastatic cancer or other life-limiting problems. So we have a real range of age. Certainly, on average, our patient is older than 70, but many are younger.
Just another comment to the direct admission, and I know we've spoken about this before, Patty. As a family member who cared for somebody who died at home, knowing that that was an option if you couldn't do it anymore, to be able to call and say, I can't do it anymore, and know that that process was there. That meant I didn't need it, but it meant all the world. Yeah.
I think that is huge. When I worked in the community, families commonly said that, Carla. So I think that is a really important point, that yes, there's those 9 patients who came in directly, but there may have been other patients whose plan was to stay home and only come to hospital if they couldn't manage. And there's something about knowing if they can't, that hopefully we can avoid the emergency department. So I think that's a very good point, Carla.
What's a question for both of you? I guess big picture, Dartmouth-wise, is there a hospice plan to mirror the one in Halifax? And what's the state of that, I guess, and then outlook?
Yes, right now we have a business case before government to bring a hospice to Dartmouth, partnering with Halifax Hospice. So that's going through government right now. So
And a similar bed capacity kind of?
I think they're looking at, I think studies would say that Halifax needs, based on our population, about 40 to 50 beds of hospice. I'm hoping that we could do 15, perhaps more, building on these.
I think Halifax Hospice is looking at the next hospice being on that Dartmouth side of up the river, and then eventually one perhaps in Bedford-Sackville area. So I think there's 2 probably in the future, and hopefully the next one in Dartmouth. That's really exciting. Thank you.
Thank you, Patty. We've got some more youths to show up. Spread the good word. We're going to have Riley Stewart talk about laparoscopic sleeve gastrectomy. Riley's bio was, as I would expect, it was absolutely perfect. He was born in Nova Scotia. He's been with Dartmouth General for the last 5 years. Undergraduate studies at the University of Waterloo, medical school at Dalhousie University, fellowship in minimally invasive surgery, including bariatric surgery at Dal, fellowship in advanced endoscopy from Dalhousie and Harvard. And we're certainly glad to have him. And he's as dynamic as a speaker as he is a worker. We're going to get a whirl with him.
Maybe not quite as excitable on the podium as in the operating room, but that's all right. But I'm starting to wonder after listening to Mrs. Burns speak about health records, and Jen, whether you whether you ask health records for all the delinquents to decide who's going to present today. Anyway, I'm very fortunate to be working in Dartmouth because we've got an amazing team in Dartmouth. And actually, I started in Dartmouth as a medical student, as a first-year medical student. I did an elective with Doug Legay, actually, and really enjoyed Doug Legay, but not what he did. So anyway, so I've been in Dartmouth a lot. But very fortunate to have a hospital with an amazing administration, and an amazing foundation, amazing nursing team, and allied health professionals. It's really allowed for me to do some of the most minimally invasive things we can do for surgical problems, laparoscopic surgery, and I'll talk today about bariatric surgery, but also therapeutic endoscopy, really giving our patients the best possible minimally invasive care, just like Jen talking about the robot as well. So even though I'm talking about a bariatric surgery, really this talk is about obesity and the big problem that obesity is in North America. And so this is, there's a report card that's done every few years on the approach to obesity in Canada and how we're doing in our management of obesity, medically, surgically. And so the most recent report here, you can see that 26.9% of patients, of people in Canada are obese, which is a body mass index of over 30. And Nova Scotia is right up there. So we're sitting here at, got a little pointer right here, at 34.6%. Prince Edward Island is below us. Newfoundland, New Brunswick, and Saskatchewan barely are above us. So we have 1/3 of patients are obese in our province, and it has impacts on metabolic diseases, it has impacts on cancer, it has impacts on arthritis and joint, and we need better ways to avoid obesity, but unfortunately we also need to accept that it's a problem that we need to be able to treat when it occurs as well. So when we talk about obesity, there are several classes of obesity. And so body mass index is simply just a height and weight measurement. It's not perfect. Big weight training, muscle people would have a high body mass index, but would not necessarily have the health implications of that higher body mass index, but it's generally pretty accurate. So obesity class 1 is a body mass index of 30 to 35, 2 is 35 to 40, and obesity class 3 is greater than 40 body mass index. And what we see, so these are the numbers of obese patients in Canada, and they've been on the rise. So from 2009 to 2017, which is the most recent census data that I had, we're talking about an increase in class 1 obesity, so 30 to body max 35, 3.2 up to almost 3.8 million people fall into that category. For class 2 obesity, we're up to almost 1.2 million folks. And body mass index over 40 has had a huge increase from 370 to 570. So it's almost a double increase in the number of people with class 3 obesity in Canada in the last basically decade. And sadly enough, there's a lot of stigma associated with obesity, and people have not recognized until very recently, or have not been willing to look past their bias and judgment about obesity to recognize that it is a disease. It is not someone who has an inability to go to the gym or stop eating that extra whatever they're eating. It is a chronic disease. And it was not until 2015 that the Canadian Medical Association recognized that, and Doctors in Nova Scotia ourselves, only this year, or I guess last, has recognized it as a chronic disease. And that has huge implications in our ability to treat it, because insurance providers aren't going to cover treatments for obesity if our medical associations don't consider it a chronic disease. Our government won't fund programs to help these patients if our medical associations aren't suggesting that these are chronic diseases, which they are. So for me, it is a lot about bias, and it is a lot about how we see obesity, and as opposed to me attempting to, I'm going to show you a video, basically, not the whole video, but I think this really sums up sort of some of our thoughts and feelings of obesity that we all have, and I'll let it play here if I can find get it to play. Here we go.
There's weight bias. Weight bias refers to our own individual attitudes and beliefs about obesity. So, what we believe that people with obesity are lazy, undisciplined, lacking willpower, ugly, not very smart, unintelligent. Those are personal beliefs that we hold about people with obesity and obesity. Or we may believe that obesity is caused by just simply overeating and lack of exercise. Those are our own attitudes about obesity and people with obesity. Weight stigma, on the other hand, refers to the social stereotypes that we have in our society. They're very deeply ingrained in our society. So the stereotypes that people with obesity are a burden to society, that people with obesity eat too much, that people with obesity don't exercise enough, or that they are less intelligent. Those are deeply ingrained in our social system, in our social structures. And then weight-based discrimination is the last term that people tend to use. And that, for me to understand it better, is when we act on our personal attitudes, our weight bias attitudes, and the social stigma and the weight stigma that exists, the stereotypes that exist about obesity, and treat people differently. So discrimination is when we treat people unfairly. So weight bias is personal attitudes, weight stigma is social stereotypes, and weight-based discrimination is when we act on those bias attitudes and stereotypes to treat people with obesity unfairly. So that's how I understand it. That's how I simplify it.
So it's really a top-down problem, because if we don't have a society that, and our medical institutions who are now only slowly appreciating this as a chronic disease, if we don't, from a top-down approach, teach as a society that this is a chronic disease, then it's very difficult for us to get rid of those individual biases. And then there's going to be those things that we act on, even if it's not overt, even if it's something that we don't even realize we're acting on because of those biases that have been so deeply ingrained. So this is, obesity is a big problem, and there's a multidisciplinary approach that we need to take to obesity. And hold on, it's just not going to the next slide. Just give me 1 second. There. And so the multidisciplinary approach to obesity is complex, and so there's numerous treatments for obesity. And the one that we all know is diet and exercise. And while, if everyone exercises and eats the right thing, then it's all going to fall back into place, and everyone's going to look like, the front of Glamour magazine, and all will be well in the world. So, and what we know is there's been numerous trials and studies that have looked at patients that are obese, and they've had all of the supports in the world, published in big journals like the New England Journal of Medicine. People followed for 5, 10 years, and they have intensive diet and exercise interventions with all those supports that they need, and only 5% of people can maintain weight loss. And so diet and exercise is important for healthy living, but it does not treat the chronic disease of obesity in most patients. Medications, there's a lot of media about medications. Ozempic and Saxenda are the two common ones that are available in Canada. Interestingly enough, the dose of Ozempic that was used in all the weight loss trials is not available in Canada, so the patients that are getting Ozempic aren't even getting the real dose of Ozempic. And there's a few others that are coming down the pipe, but insurance providers don't cover them for the most part. They're expensive, and they do work, but they only help people to lose about 10% of their excess body weight, which is great. It is very good, and we should be using these, but it is only a component of the multidisciplinary approach to the treatment of obesity. And, a lot of these medications, even if they weren't covered, taking these medications for years and years and years and years isn't necessarily a realistic end treatment goal for everyone. So the thing that I'm going to talk about today in more detail is surgery, of course. And bariatric surgery is also not perfect, but weight loss or bariatric surgery has been around for a long time. There's lots of different surgeries that are available, and some are historical or we don't do much anymore, and some are more frequently used. So here's some pictures, sort of just to try to explain something. So in the 70s, 80s, and early 90s, even here in Nova Scotia, they were doing what's called a vertical band gastroplasty, where they would you'd get a big incision because they weren't doing anything laparoscopic at the time. They'd make a hole in the stomach here, and they put some staples here so that food couldn't go down this way, and they put this mesh band right here. And so that the food would go down through here, and it would have to go through this mesh band, and there would be some restriction to eating, basically. And, this was a good attempt at a weight loss surgery, but unfortunately this band gets narrow, more and more narrow, and probably 3 or 4 patients a year I have to do an operation to release that band. So it's not a good operation, but it was an attempt at an operation. There used to be an adjustable gastric band as well, would have a little balloon attached to it that you could inflate. And this is relatively historical as well. They don't do this that much anymore. The two that are most commonly done is the Roux-en-Y gastric bypass, which is a much bigger surgery because you have to actually reorganize the anatomy of take a piece of the small intestine, bring it to the stomach. So there's a lot more surgery, and there's a lot more potential complications to that operation, but it is probably one of the more effective operations, but only barely compared to the sleeve gastrectomy, which we do in Nova Scotia, which removes 80% of the stomach, but does not reorganize any of the anatomy for the patient. And so because you're not reorganizing any anatomy, the risk of complication is much, much lower, but it's still quite an effective operation. So I'm going to talk a little bit more about that. So first I want to get in again to, this goes back to stigma and and its access here. So this is the number of bariatric operations done by province between 2009 and 2017. And if you want to look at Nova Scotia there, 50 bariatric operations per year are done for an entire decade. We've only had one surgeon doing bariatric operations, compared to thousands in Ontario. And Ontario doesn't have 1,000 times the population of Nova Scotia. And if you look at, this is the number of people that are getting bariatric operations. So you look at this line, this is the number of people that are eligible for bariatric surgery that have tried to access it, that actually successfully get bariatric surgery. And you can see the numbers are abysmal everywhere. So this is the grade, so this is an F. And Nova Scotia gets a big capital F, basically. So 1 in 1,073 patients that are eligible for bariatric surgery get it. And we get all this, I'm not sure why it's not yeah. Is this not on? Oh yeah. Oh yeah. It's okay. Oh yeah, you can log it in. I can talk a little bit more. So basically,
You take the microphone.
yeah, I use the microphone. Yeah. Taylor Swift here. Okay. So one in 1,000 basically, and the big reason for 1 in 1,000 in this province is that we don't recognize it as chronic disease. So the government won't fund multidisciplinary clinics. So you can't just take somebody, see them in your office, take out 80% of their stomach and expect them to succeed. So patients need to be seen. They need to have an assessment of the psychological, dietary, and sociologic factors that are associated with how they became obese. And you need to give them the supports to address those problems. and to develop new coping mechanisms so that they can succeed with surgery, because medications, diet, exercise, surgery, they're all tools in the treatment of obesity. And if there are sociological or psychological or other chronic disease medical problems that are making it impossible for those components of weight loss management to work, then all of those together or in silo are going to fail, basically. And so because we don't have funding for a very large multidisciplinary program, we never had more than one bariatric surgeon until recently. So now we have 3. I'll talk a little bit more about that. And even though we have 3, when we ask for more funding, the administration and government says, well, there's not that many people on the wait list. What do you need more funding for? And they're on the wait list because they can't get seen to be put on the wait list because they can't get through the program because they can't access the program. So we have now, have sort of given up on the idea that they're going to give us more money up front, and so we have more surgeons doing the surgery, so that more surgeons are seeing people. So now we're trying to go back to them and say, okay, there's more people on the wait list, are you ready to play ball now, basically? And so we're trying to get a larger multidisciplinary program so that we can succeed in the treatment, the multidisciplinary treatment of weight loss. And that doesn't mean just surgery, right? This program would include all of the factors of weight loss, because not everyone wants surgery. In fact, the vast majority of people that want weight loss management don't want surgery. But that doesn't mean that they shouldn't still have access to a multidisciplinary clinic. For example, joint replacement patients could have access to a multidisciplinary clinic, and they can have better outcomes if they lose weight before their surgery. That might include bariatric surgery, and we're actually doing a study to see whether that holds true. But we need these multidisciplinary clinics to be able to offer that. So let me just get this back up here. Okay, we're back in business. So I mentioned all this. So now there's 4, and I'm doing sleeve gastrectomy in Dartmouth, which I'm quite excited about. So it is a laparoscopic surgery, and so it's just gives you an idea. They're kind of in the operating room there, and they've got these very small incisions. And I'm going to show you a video of actually what the surgery looks like. So this isn't me doing it. I didn't have time to edit any of my videos. I apologize. This is somebody in Boston. They do an okay job. It's not. It's not great. Anyway, I'm just going to turn the volume on. So I just want to get through this video and show you a little bit about the surgery, basically, so you can see kind of what we do. The surgery takes about 90 minutes for most patients, and it's relatively straightforward. So this is kind of fun there. So that's the stomach. The gallbladder is that little blue bag to the left there. And the whole idea, like I said, is we're trying to turn the stomach into like a long tube instead of a larger bag, basically. And so the stomach has numerous blood vessels, basically. And so the whole idea is you first have to sort of detach it from a lot of blood supply there. So that's what we're doing right here. This would be very similar to the way I do it. And so we use these nice energy devices that seal off all the blood vessels and move along sort of. And so coming up here, that's the spleen up here. So we try and be careful not to bother the spleen. And the stomach basically, once it's all sort of cut away from its blood supply, we put this tube down called a bougie. It's about, probably about the size of my thumb. And that's how wide we're kind of making the, what we call the conduit or the sleeve. And so by putting a tube down there, I can make sure that it doesn't matter who the patient is, they get exactly the same operation. So I'm going to staple along the tube let's see if we can get the stapler going in here. Where's our stapler? Oh, Is it there? Oh, there we go. So yeah, so now we got the tube in there. What we do is we actually staple along the tube to make the stomach into basically a long conduit. So let's see how they go. They're gonna keep going slowly but surely. And here we go. You can start to see how it takes shape into like this long tube here. And theoretically, you want the staple line to be perfectly straight. There's a little bit of zigzag, but that's all right. I have a problem, so like everything has to be exactly straight. So it's just like generally like control problems. So this is the idea. So we staple along the whole stomach, right? And you turn it into this long tube, basically. And then we remove that part of the stomach. But the, and like I said, the operation takes about 90 minutes, and I'll just sort of end this and move on to the next slide. That'll let me. Here we go. So the important thing is it's not a cosmetic surgery. So obesity is a chronic disease. It's not a cosmetic surgery. The whole idea is not to turn somebody who has struggled with obesity into someone who is what society would deem or consider normal weight. And that's not our goal at all. And in fact, that's not an achievable goal in most patients. What we're trying to do is we are trying to allow an amount of weight loss that decreases their risk of early death by obesity-related comorbidities like heart disease, lung disease, and cancer. So all of these, this is the only goal of surgery. And so in achieving weight loss from surgery, which you would get about 20% to 25% of body weight reduction. So for someone that's obese, that's somewhere around like an 82 or greater weight loss that is sustained over, if you take large studies with tens of thousands of patients, and there's always going to be failures, but if you take 10,000 patients and you do this surgery, and there'll be 25% weight loss at 1 year, and then it'll creep up at 2 years to 20%, and it'll stay at 20%. So there's a sustained weight loss in these patients for 5, 10, 15, 20 years. And there's huge effects on that, and I'm going to show you what some of those are. So here's the first slide just showing, these are huge New England Journal of Medicine trials. These are not little baby studies. And they're showing that with diet and exercise, which is the blue line here, there is a little bit of weight loss, and then they gain it all back, which is exactly what I described to you. And then with weight loss surgery, there's, like I said, there's about a 25%, so their body mass index drops from 40 to 30, right? And what's important there, it's not 25, but it's 30, and that's a huge difference, and you'll see why. So it drops down to 30, creeps back up a little bit, but basically stays the same. So weight loss surgery has complications. It is a surgery, but it's effective. It works. And here's how it works. So if you look at someone's life expectancy, so they've got a reference range, which is the purple line right at the top. We have the surgery, which is the orange, and then we have a control group, which is the blue. So you can ignore the reference line, but if you look at the difference here, I'll see if I can get my pointer over here somehow. Here we go. So if you're looking at, this is 20 years out. So this is somebody with obesity who does not have surgery, who's managed medically with usual medical management, so they do diet and exercise every once in a while, their weight yo-yos, their diabetes is managed maybe well, maybe not, by medications, blood pressure is managed by medications. You can see that there's a significant difference in the life expectancy of someone who's had weight loss surgery versus someone who is not. So weight loss surgery with sustained weight loss management on top of, instead of, on top of usual medical management for obesity and the comorbidities like diabetes, means that they're going to be alive longer at 20 years than someone who's not had surgery. So weight loss surgery works. And so weight loss surgery, again, is people think of it as like tightening up the stomach or making it small so I can't eat, I get full faster, and that's true, you might get full faster, but it's a metabolic surgery. So when you remove a portion of the stomach, you decrease hormones that affect satiety, affect someone's hunger level, and hormones that affect how you manage blood sugar and how you manage converting sugar into fat and storing it in fat tissue. So it is a metabolic operation. And The patients that actually we are seeing now that benefit the most from this operation are young patients that are in their like 40s or 45, or even younger, 35, 30, that have early onset diabetes. And you do this operation, I'm going to show you some more data about that in a second. If you do an operation on a young person with new diabetes, you can arrest the need for medications in diabetes for 5 or more years in patients like that. So that's 5 years they're not on medications for diabetes, 5 years where their sugars are not higher and they're accumulating the long-term damage to their kidneys, their arteries, and their heart that occurs every year with diabetes, managed medically or not, for 5 or more years, basically. And so, if you look here, this is sort of a busy sort of graph, but these are more studies, but I'm going to focus mostly on, this is your hemoglobin A1C. So they're using gastric bypass and sleeve gastrectomy, which are the 2 most common surgeries done in North America right now. Basically, you can see that the medically managed folks that are hemoglobin A1C, they have diet and exercise and they're followed very closely, is their hemoglobin A1C comes down a little bit, kind of like surgery, everyone's doing well, and then over time they're doing all the same things, nothing's changed, medical management, exercise, diet, people seeing you 3 or 4 times a week, and it starts creeping back up to 7 and 8, right? After surgery, we're looking at 5, 6 years out, their hemoglobin A1C is still in the 6 range after surgery. So it's a metabolic operation that works, okay? And then if you look over here, it's a very busy slide, and so I'm not going to try and, I'll try and break it down as much as I can. I'm going to do my shell again, but basically this is medical therapy, okay? And this is looking at, so the light blue is the amount of people that are on insulin before they enter into the program with diet and exercise and being followed by an endocrinologist or an internist. And this is 5 years after. So there's virtually no change. So 53% on insulin, 40% on insulin. These are the other medications. And so almost no one's on no medication. Here's sleeve gastrectomy, which is we do or bypass, but let's look at sleeve gastrectomy. So 43% of people at the beginning of the study, only 11% of people 5 years out from their operation are still on insulin, and 25% of people are no longer on any medications for diabetes 5 years out from their surgery. So this is a surgery that works to manage diabetes and should be a main indication for someone to have surgery is poorly controlled diabetes with obesity. And we know that obesity is associated with cancer, and we also know now, and we've been seeing this anecdotally as providers, as nurses and physicians, that cancer is occurring at a younger age in our patients, and it's occurring more frequently. Even though we're getting better at treating it, and less people are dying from certain cancers, they are occurring more frequently, okay? And they're mostly occurring in young female patients, and in patients, colon cancer, breast cancer, biliary tract cancers, and interestingly or not interestingly, probably associatively, is a lot of these cancers are associated with obesity. So are we talking about an obesity problem or are we talking about something different? I don't know the answer to that, but I wonder whether it's an obesity problem as opposed to something else. It's hard to know with all of the environmental factors we're associated with, but cancer is happening more frequently, and all of these cancers that are listed up here are associated with obesity. So if you look here, these are these same sort of studies. So usual medical management, diet, exercise, seeing an internist versus weight loss surgery. So this is all cancers. So if you just take people with all cancers, the number of cancers in patients that have had bariatric surgery is significantly lower than those with standard medical management for their obesity, okay? Cancer rates are lower if you have weight loss surgery. This is obesity-related cancers, and you see the same thing. So cancer is lower in patients that have weight loss surgery, who are, as opposed to having usual medical management, basically. So, nothing's perfect. The medications that you see advertised online have risks, and they talk about those on TV, and there's class action lawsuits for medications, but those risks are low. Complications for the surgery that I do, relatively low, so the mortality rate is equivalent to getting your gallbladder out, basically. There's a small risk of bleeding, leak, having that area narrowed down, have to stretch it, or getting, we do give you blood thinners, but things like pulmonary embolus, so blood clots to lungs, legs, heart attacks, or strokes. But all in all, is a relatively low risk surgery for a potential very high gain for the patient. One of the other things that's an issue with some of these surgeries is can get some reflux after these surgeries. It's talked about quite frequently, so I thought I'd mention it. While reflux is very common, so 40% of patients have reflux, and obesity worsens reflux. Weight loss surgery can cause a difficulty with reflux, but almost always it's treatable. So it's a downside, but it's also it's something that's treatable, and much more treatable than uncontrolled diabetes, hypertension, and other obesity-related difficulties. And there's all sorts of other applications for weight loss surgery other than diabetes and all this stuff. So lots of people that have sleep apnea, so sleep apnea, well controlled even, but also poorly controlled, puts people at risk of heart attack and stroke, and significant lung complications. And the ENT folks say the same. They don't have access to bariatric surgery, but a lot of the surgeries they do, like cleaning out the nasal passages and all of that stuff, are much less effective than weight loss surgery for sleep apnea and for resolution of sleep apnea. So if there was better access, they probably would be involved in that. So the good news is that we are trying to increase access, thanks to getting the equipment, which was a help of the foundation, and thanks to our administration, allowing us to start this operation. We've now increased. Now we're doing about 2 to 3 times more bariatric operations in the province, which is still staggeringly low, but we're getting there. We're pushing our way there with the support of the people there. And so what we're doing for our program, so we're doing low-risk patients in Dartmouth. So everyone gets seen through our central clinic. Like I said, the most important part of weight loss surgery is the clinic and the multidisciplinary approach. They get seen by our clinic, and the low-risk individuals get sent to Dartmouth. And so after they've seen the dietitian, the psychologist, and the nurse practitioner, if their body mass index is less than 50, and the reason for that number is that there's just a higher complication rate if the body mass index is up, so we do the low-risk patients. No major medical comorbidities, and the whole idea is these patients stay for 1 day, so they just stay overnight. And if we can manage to get more funding through the program, we'll actually probably start doing a very similar model to the orthopedic team there, is where hopefully we'll have a nurse practitioner on site, and they won't even stay overnight, basically. They'll have their surgery in the morning, they'll start advancing their diet to make sure that they can eat without nausea and vomiting. Their nurse practitioner will be there to coach them, and they'll be discharged that evening, basically. So that would be the goal, and our patient population is going to be the perfect to do that, basically. So this is just a little bit about what happens when they're in a hospital. So basically, they come in, they have their surgery, they start drinking fluids right away. Most patients have some nausea and some heartburn. We just treat that medically, and it goes away over weeks after surgery. They get anti-nausea medication, pain medication, and we get them walking right away. And they go home on various prescriptions to manage some of their symptoms. And most people do pretty well. We have a small subset of people that struggle with severe nausea and vomiting for several months after the operation, but the vast majority of people feel not their best health, but pretty decent. And they move along to like a full diet, basically a normal diet, just smaller meals more frequently, and that's like a lifestyle change long term, sort of within 3 months after surgery. So vast majority of people do well. They'd be expected to lose sort of 20 to 25% of their weight, and that translates into a longer life with a better quality of life, a lower risk of cancer and diabetes and heart-related complications, basically. So basically, to summarize, obesity is a chronic disease, and I can't stress that enough. There is stigma up the yin-yang related to obesity because we don't recognize it as a chronic disease. It needs a multidisciplinary approach. Surgery is just one of those prongs. But we do know that intensive medical management is inadequate for long-term control of obesity and comorbidities. And we all have people that are that have wonderful motivation, and They've done excellent and very well with diet and exercise, and all the power to those people. But it is a small subset of people. Most people struggle, and they continue to struggle. And so the expansion of bariatric surgery in Dartmouth has improved our province's poor access, and hopefully the expansion of bariatrics in Dartmouth will hopefully improve our ability to convince our administrations and our governments that medicine should not be reactive, but it should be proactive. And proactive treatment of obesity means multidisciplinary clinics, access to medications, and access to surgery. Thank you very much. I'm going to use the whole time. Yeah, go ahead.
Can you speak to what the comorbidities might be that might prevent someone from being independent of breast?
Yeah, so we were asked to repeat the questions for the online folks. So yeah, the question was about what comorbidities would make you ineligible for bariatric surgery. So I think basically advanced heart and lung disease, incurable cancer, those are generally the things that make you ineligible. At one time, age was a factor, but it's less so a factor because we know that frailty is a much more important indicator of health status as opposed to age, and so we don't really think as much about age as we used to.
And just one more follow-up. Is it possible to have this surgery now in Nova Scotia at no charge because there's a certain recognition that you talked about?
Yeah, so bariatric surgery, the question was a charge. So there's no charge, so it's covered by MSI. It's a little bit difficult, as Dr. Davis and I were talking about, getting, once you lose all the weight, getting skin taken off, getting a plastic surgeon to do that at no charge, but we do find ways to get there. But it is covered, but lots of people, because the access is so abysmal, 1 in 1,000, as I showed you, basically, like lots of people, they go to like places like Mexico, like travel medicine, like, we see families, they offer discounts if you go with your families. You get 10% off each if you go, it's no joke, it's like, it's big business down there, right? And they, and they do good, these places do some good surgeries, but they do a one-size-fits-all surgery, and not everyone is exactly the same, and so you can't, just, everyone's stomach out without being thoughtful about it, because not everyone needs exactly the same approach, basically, so. Any other questions, Tom?
Yeah, right. Go ahead.
What's, in terms of recovery physically, like returning to normal activities, what's that look like?
Yeah, I'd say that so the question was about a return to normal activity and recovery. So a lot of it depends on tolerance to the diet after. So in the patients that I see at 4 weeks that don't have any difficulty with the nausea and vomiting, like within 2 weeks they're fine, and within 4 weeks they're back to all of their usual activity. In the patients that have trouble with the diet, they have nausea and vomiting, they're not feeling their best self, they're not really getting the calories that they need initially. And while that helps with the initial weight loss, it doesn't help with them getting back to their activity. So sometimes people are several months sort of before they feel their best self. Because part of it, like, it's very important, when I see people, it's very important that they have a plan going forward for regular exercise and regular dietary stuff, and that they've thought about what coping mechanisms they may now have if they have some hiccups. And so, we get people, I try and get people, we have them exercise in the ward right away, like walking right away, but I try and say, by the time I see you at 4 weeks, you should be kind of back to close to what you were doing before surgery in terms of exercise. And most people make it there, not all.
We, in plastics, have a problem with this obesity problem with breast reduction surgery. And they used to restrict access if the BMI was above 30 to 32. And in the last 4 years, they've taken that restriction off. The Department of Health and the governments have not caught on, like you mentioned. I know from doing breast reduction surgery for years and years and years, that this is not a lifestyle, that the obesity is not a lifestyle. It's actually a disease as you described, and probably the most rewarding surgery that plastic surgeons do is breast reduction surgery. They're the happiest patients that we have, and they just, it's only within the last 3 to 4 years they've dropped that weight restriction.
Yeah, it is a big problem because government doesn't see it as a chronic disease, and even, like I said, our medical associations are now just recognizing it. And it's important to note that like most people with obesity are not actually going to undergo surgery, but that doesn't mean that there's, like I said, these multidisciplinary approaches are important. And, it's hard in North America because some of these Scandinavian countries, for example, like physical activity is part of their life very early on. And they don't really think of it as like, I gotta make sure I get to the gym 3 times a week. It's just kind of like they go about their day and there's physical activity there. And so the rates of obesity are quite low. Whereas North America, we've gotten to this point where I'm not sure, it's very complex obviously how we got there, but like early healthy living is very deliberate, whereas in some of these other countries it's not so deliberate, it's automatic. And so I think obesity is here to stay because I think it's going to be very hard to switch North American culture back to an automatic, early sort of approach to healthy living as opposed to a deliberate or reactive, not dissimilar to our healthcare system approach to obesity. So, yeah. Thank you.
They don't.
That was excellent. I was pretty impressed with how you took us through those complicated slides. Normally, they forced me my brain down with you with all the graphs. That was good.
I just ignored the whole concept of that. Studied it for a week.
Well, now we got another you. And John's going to talk about what's new in urology at Dartmouth General Hospital. So John gave me his, he did comply, but he was recalcitrant, reticent in giving me his vial. So anyway, he tells me that he's born in St. John, New Brunswick, medical school at Memorial University, residency in urology at Dalhousie University. He did a fellowship way out west, where there's lots of football, MD Anderson Center in Houston, Texas in urologic oncology. Now, I've had the opportunity to operate with this guy a couple of times, and it is an experience. He is high energy, knowledgeable, passionate about what he does. So I expect a pretty good session this afternoon.
Thank you. Question?
Question?
Well, thank you all for taking the time now. Thanks everybody for coming, devoting a half a Saturday to this, and really appreciate it. Thank you so much for hosting, and thanks George for being here. Thanks everyone. An excellent talk so far. It's funny, like you said, all of us at the same year, we went to med school at the same era, residency, same era, and here we are, kind of grown-ups, I guess. So, this talk today, I could speak here for hours, but I know in the last talk I'll try to get through it in an appropriate time frame. So, what's new in urology at Dartmouth General is kind of the main focus of the talk. There's a couple of sections to the talk which we'll talk about, but at the end of the day, the answer is simple. Everything's new. We had excellent foundations in urology when I arrived. Dr. T and Dr. Chun, decades of excellent work in urology, but with new people comes new procedures and new toys, and really everything is new in urology, and that's what you'll see going through the slides here today. So what is urology? I had to put this slide. A lot of people, there's a lot of confusion about what urology is. A lot of people think it's only males. They think I have an only male practice. I don't see females at all. A lot of people think we're nephrologists, that we give dialysis and deal with chronic kidney disease. We just remove kidneys sometimes and do stone treatments, but certainly not nephrologists. And on call, we get a lot of calls for neurology. But obviously, we're not neurologists. That's just a nice call we get in the night, and I'm very happy to get that call sometimes because it means I don't have to do anything. So, you know, we're a small but mighty department, I think. It's a completely new department. There's a lot of similarity, which you'll see. Just John and I, and John. So there's two of us. This is me, Dr. Davis, kind of already went through all the stuff already. From the Maritimes, trained here, but I did go away to the States, and it was an invaluable experience, as I'm sure everybody else can say. I mean, this is what brought a lot of these ideas home. You go away, you see how things are differently, and you bring it back and try to get it up and going here. So, and John, the same thing. You know, it's another John in Dartmouth General, I know. There's two of us, our whole department is John. A lot of similarities. We're both from St. John. We both essentially trained here. Both went away to the States and are basically share practice at Woodlawn. So, like I said, there's two parts to this talk. The first part is going to be quasi-educational about urology, how we do things in the OR now, in the clinic, and stuff like that. That's new procedures. I'll be honest, a lot of these procedures are not new per se, but they're new to Dartmouth. They haven't been done here until we came back, and really new in our hospital for sure. And all the new equipment, which is essentially everything we use on a day-to-day basis, is new. And I've been back, I think, 3 or 4 years now, and that's a lot of change in 4 years, going from, you know, essentially having a whole new platform of equipment for urology, thanks to the foundation, obviously. So, yeah, it's funny, I always say this, I didn't really know Dartmouth General. I trained in Halifax and spent all my time there, and I came back, there was a job opportunity, and you kind of come back and start work, and I mean, Riley might have been the same, I'm not sure, well, Jen was over there too, but you kind of think, okay, I'll start working at Dartmouth, and then we'll go citywide, I'll be at the BG, coming back, but, you know, opportunities have come up, and I'm never leaving Dartmouth, like, that's just, and things are growing at a rapid pace, especially in the urology department. So, the things we'll highlight today, bladder cancer is by far the main part of my practice, so we'll definitely be talking about that. Clinic-based bladder cancer therapies, which some of the clinic nurses are here, will know well about that, and then the surgical changes as well. Treatment of complicated upper urinary tract stones. A lot of the stones that were sent to kind of us in Halifax when I was a resident. Minimally invasive kidney surgery, not a new procedure, but certainly new to Dartmouth. Some newer BPH procedures for enlarged prostate, bread and butter urologic procedure entity. Shockwave is new too. We'll briefly touch on that. That's a whole new component to Dartmouth General. And then microscopic infertility procedures are being done now at Dartmouth too with one of our colleagues that practices mainly in Halifax. So the way we'll kind of go through it, I didn't know how to kind of structure the talk, but I thought this would work well, just kind of a general overview. I mean, this is urology. Kidneys, ureter, bladder, prostate, and external and male genitalia. So we'll kind of go through it, just organ-based, how things have changed, what we're offering now, new equipment we have, and take it from there. So bladder-wise, there's been a lot of change. That's probably, like I said, the bulk of my practice, other than general urology, is bladder cancer for sure. Bladder cancer is a very common entity. You know, this is probably data about 3 or 4 years old now, 80,000 new cases, 17,000 deaths annually in the USA. It's a disease that goes on for, the one thing I like about urology and managing bladder cancer patients is that they're your patients forever. So basically they have a diagnosis, you treat them, and they're followed their entire life. Bladder cancer has a very high recurrence rate and a fairly significant progression rate. So patients that kind of blow through therapies and end up needing more advanced therapies. But These patients are not one and dones by any means. You get to follow them, you scope them all the time. I'm sure the endo nurses see the same patients coming back all the time. And you really do develop a nice relationship with them, which is a lot of things in urology are like that, kind of more longitudinal follow-up. Smoking is a huge risk factor for a lot of cancers, and mainly bladder cancer. Well, why is that? Well, it's the carcinogens basically dwell in the bladder, and there's constant exposure to the urothelium sitting there and causing mutations over decades. And even for people that quit smoking 10, 20 years ago, they're still affected by the years of basically carcinogen exposure in the bladder urothelium. It is arguable, there's definitely data to support this, it is the most expensive cancer to treat, and that's really because of its longitudinal nature. The patients are coming in, the surgeries per se are not super expensive, but they're coming in, they have their initial surgeries, and then the scopes, they're scoped every 3 months for 2 years, every 6 months for 2 years, and once a year annually, like for their life, for high-risk bladder cancer. And basically, if they recur, that whole cycle basically shortens up and goes faster. So, bladder cancer itself, just so you'll kind of understand what we're talking about going through it, the way I explain it to patients, and a lot of nurses have heard these talks, but the way I explain it, basically you think of the bladder like a balloon. All the cancers start on the inside of the balloon. And what dictates your management in bladder cancer simply is how far the cancer has grown into the wall of the balloon. How deeply rooted has the cancer got? So in endoscopy, we scope people, we see the tumor, that's all the information I have. We have to go in, resect the tumor, and see how far it's gone into the wall. And it's an interesting disease in that just one cell layer, basically going from non-muscle invasive, just on the inner lining of the bladder or slight roots, to having cancer cells in the muscle of the bladder, which is literally one microscopic layer. You go from keeping your bladder and just coming to the clinic and having medicines in your bladder to having your bladder removed with a stoma, basically. Yeah. So that's why it's critical to follow these patients closely and try to prevent that from happening. So getting to our theme of the day here, new staff to Dartmouth General. So the first part is just about non-muscle invasive bladder cancer, which is the bulk of patients. I mean, the 70–80% of people with bladder cancer are not muscle invasive. The backbone of treatment really is this medicine called BCG. This isn't new. It's been around for decades. It's an immunotherapy, really the earliest immunotherapy we've had. It's just simply a medicine that's given in the bladder. The patients come into the clinic, catheter goes in, the medicine goes in, and it basically causes a profound immune reaction to activate the patient's immune system to try to fight the cancer, preventing recurrence and progression. It's been around for a long time. The urologist, Dr. Tien, Dr. Chan, certainly Dr. Tien, gave this in clinic himself, and it's been totally transitioned to a nursing role now in our clinic. The volumes were just profoundly high. I definitely have the highest volumes probably in the province for patients on BCG, so it was just not sustainable sending everybody to Halifax, number one. Number two, they didn't want all my patients over there because it was too many. And third, and by far the most important point, is that people don't want to go. They live in Dartmouth, they live on the Eastern Shore, they want to come to Dartmouth General, have their scopes, have their treatment, and go home. Okay? And that's something, again, just a side note. I didn't appreciate that until I started working at Dartmouth General. It came up earlier. People really don't want to go to Halifax. I think they're like, oh yeah, I'm just driving across the bridge. Not at all. It really causes a profound amount of anxiety for patients, especially elderly patients. And in urology, that's the bread and butter, elderly patients, and extremely frail. And anesthesia as well. So the benefits are obvious. I mean, it's convenience for patients, continuity of care, and obviously nurse administered now, just surely because of the volume. And that'll be done in our new pelvic health suite eventually. It's just kind of smattered amongst the clinics now, and the whole second part of the talk's in the pelvic health suite. The surgical management of bladder cancer, really the newest thing, new to Dartmouth General, is just management of advanced bladder cancer. So patients that do need to have their bladder removed, it's a big surgery. It's the biggest surgery we do as urologists. And when I first came back, I still did them in Halifax. I went over there, and I still operate there too. But with the team in the OR and the nursing team on the floor, pre-op PACU, it was a it was a completely seamless transition just to start up one day doing this major surgery in Dartmouth. It wasn't a big deal at all. So what is a radical cystectomy? Well, it's the way we treat muscle-invasive bladder cancer. In a male, and the nurses see these come to the floor, what gets removed? The bladder, the prostate, lymph nodes, and then we have to recreate a urinary diversion. In females, it's the bladder, the uterus, anterior part of the vagina, tubes, ovaries, basically a full anterior exenteration. So that's basically what the surgery is. This is just a gross depiction of it. This is a bladder, a fairly recent-ish one, I think. Just a bladder, and you can see so this is a bladder here, and then the prostate's right here, so this is a male specimen. It's an open procedure we do in the OR with obviously some support for new equipment and retractors from the foundation. This is basically an empty pelvis now. The bladder's been removed. The ureters are kind of over here. And that begs the question, and this is what people show up to my office and I say I'm going to take their bladder out. They're like, well, what does that mean? Where's the urine going to go? So this is the most common urinary diversion that we do. And it's mostly a lot of it for the nurses on the floor too. It's a procedure or a diversion called an ileoconduit. There's basically two ways we divert urine after a cystectomy, either incontinent, where they have a stoma and a bag, or continent, where we basically make kind of a new bladder at a bowel called a neobladder and hook it up on the inside. Basically in our population, the vast majority of patients end up with a conduit based on a multitude of factors. But the way I explain it to patients with urinary diversion, a conduit, it's like a Toyota Corolla, Honda Civic. It's tried, tested, true, easy to take care of. When something breaks, people know how to deal with it, and it can handle a lot of mileage. Neobladders, they sound amazing, and it is a great surgery, but they're like Ferraris. So when something goes wrong, nobody can deal with it. And they're a lot harder to manage. People have to do self-catheterization oftentimes. And people are going through a lot with this advanced cancer state. They're elderly, they're frail. They're just not in a state physically, mentally, or socially to be able to deal with that. So conduit is by far our most common diversion. This is kind of a depiction of this, again, just for a post-op talk for the nurses. Basically, I'll go back here. What is a conduit? Well, the way I think everything's simple. The way I'm explaining it, people are probably like, yeah, okay, buddy. The way I explain it to patients, essentially, all we do is we steal a piece of the bowel. The bowel's simple. It starts here, it ends here. I take a piece of the bowel away. I use that as a chimney. I hook the kidney tubes up to the bottom of the chimney, and the top of the chimney comes to a bag on the skin. So that's kind of what's depicted here. People say they understand, but I'm not sure. And so that's kind of what's depicted here. This is our chimney that I stole from the bowel, and the ureter is hooked up to it. And then this is what the nurses will see on the floor, the blue and the pink stents, okay? So the conduit bag is there, the stoma is there, the blue and the pink stents are just in the ureters. When you take the urinary tract apart and you put it back together, well, you need a mold for it to heal over. So that's the concept of the stents, okay? Post-op care, these patients, they're frail, and it's a big surgery, and they can get sick. So that's the biggest thing for these patients is kind of close monitoring. Need a drink, hold on. Close monitoring. They're coming up, they have a lot of tubes. They have drains coming everywhere, stents coming everywhere. So basically they'll have a pelvic drain, the stents, they'll have a drain. Oftentimes if it's a male, they'll still have a pelvic drain through their urethra that will remove a couple of days post-op. But the overall goals of managing, and this is why I think it was a seamless transition, the goals of managing the patient and getting them out the door from 3 East to home are really the same as a lot of the surgeries Riley does. I mean, they're big kind of abdominal operations. Patients got to get up, they have to walk, the bowels have to wake up, you have to progress their diet, they have to be able to manage their stoma, give themselves fragment, and those are the tick boxes out the door. So I think that's probably what made it kind of an easier transition, just because they're kind of so used to that stuff. So I guess we'll do questions at the end. So that kind of covers the bladder cancer stuff. In summary, nurse-administered BCG, which is a TJ, the charge nurse, and OPD says is almost like an hourly event, but definitely a daily event, and more advanced bladder cancer surgeries. Prostate, back to our diagram here, prostate's the next thing we're going to talk about. So this is, what I would call bread and butter urology. So BPH, Well, what is it? It's basically just benign enlargement of the prostate that happens in everybody. Everybody's prostate, or all men's prostate, grow as they get older. People grow at different rates, and people develop various symptoms, right? In terms of the severity is what I should say. So it's super common. I mean, 3/4 of men, or probably 70–80% of men in their 60s have an element of BPH. Whether they complain about it, recognize it or not is all variable. And the vast majority of patients, probably 80–90% of patients over 70, and you can think of now with longevity, people living into their late 80s. I mean, everybody has an element of BPH, or men, I should say. So, well, what's the treatment of BPH? Well, it hasn't changed in 100 years, principally. The options are very simple. One, you can live with it. Just observation, monitoring, and intervene if the symptoms become bothersome enough. And a lot of people choose that. It's a quality of life thing. A lot of people come in with significant complaints. We, as doctors, always think we need to give them medicines and stuff, but really it's a quality of life thing. They do stuff about it when it impacts their quality of life enough that they want to be on medicine. There's medications we can use for this, and then there's surgery, which is kind of what we'll touch base on here now. So BPH is, again, something that's been around forever. It's been surgically managed for over 100 years, but there are some new technologies and ones that we have at Dartmouth General just even since I've arrived. So out of the kind of 4-ish procedures we do for enlarged prostate, 3 of the 4 of them are new basically in the past 3 years to Dartmouth General. One of which was we did our first procedure yesterday. So TURP, everybody's heard of TURP, transurethral section of the prostate. It's a great procedure. I can't knock it. It's been around for over 100 years. Any procedure that lasts in medicine 100 years is obviously good. Otherwise it wouldn't have lasted. There's been lots come and go for BPH over the years, but it's a tried, tested, and true method of dealing with enlarged prostate. The newer technology we have for it is just bipolar. It just basically changes the solution we use, so it could be a bit better in some higher risk patients. Plasma button is something that's been funded by the foundation, trying to get people out of hospital faster. It can be done as a day procedure. It's done on smaller prostates. I'll kind of highlight that in a minute. But there's pretty good data. Everybody thinks that people with symptomatic BPH all have grapefruits in terms of prostates, but there's the symptoms can be variable. People can have a small prostate, still be very bothered about how they void. And then HOLE is a procedure. That's the one I was just talking about, watch all the Huffman diagram stuff. That's the one we did the first one yesterday. So, again, back to my so-called simplistic explanations. So, what happens, and the way I explain it to patients is that voiding dynamics is simple. It's like a sink and a drain. Well, the sink's the bladder, it has to push the urine out, and the prostate, you can think of it like a drain. Well, what happens with BPH is usually a combination of 2 things. One, the prostate's getting larger, so the drain is getting plugged up. And because of that, the sink is overworked for years, and the behavior of the sink gets deranged, and that's how people can oftentimes go into retention, usually a combination of those 2 things. Well, the sink, I tell patients, it is what it is. I can't change the sink. If it's decompensated, it's decompensated. We can't give you a new sink or a new bladder per se, but we can work on the drain. So that's really what the treatment of BPH is focused around, is drain work. So we have medicines, the main one being Flomax. I basically tell patients it's like Drano. So you just take it and try to relax the drain to help them be better. And then basically surgical procedures. So here's my sink and drain picture. So this is a TURP and plasma button. Conceptually are very similar. We approach them the same way. It's just a different way that we go about dealing with the prostate tissue. So all of these procedures, most people probably know, there's no, I tell patients, I'm not going to open your abdomen up and take part of the prostate out. It's all done endoscopically, so through the urethra. Patients come in to have an anesthetic, general or spinal, and we either go in and either scrape the prostate out with the loop. That's really a TURP, and that's been around for a long time. Plasma button's different. There's no tissue removed per se. It's vaporized with plasma technology and basically melts the tissue away, making the passageway bigger. So that's kind of the biggest thing for plasma button. One, that it can be done on anticoagulated patients or people that are on blood thinners. Two, that they can go home oftentimes the same day. And three, that it is for smaller prostates. I mean, you'd be there all day melting tissue on bigger prostates. So this is a procedure we have. The first one we did the first yesterday. This is called HOLA. So this is basically like a laser enucleation of the prostate. Prostates, like I said, they come in different sizes. Small oranges, clementines, grapefruits. All this is for the grapefruits. So we used to approach these through an open surgery that was done even just up until recently, where we would literally go in the abdomen, open the prostate, take all of the bulky tissue out, and then close the prostate back up. It's a big surgery, and it's a lot of blood loss associated with that. So now it's done with a laser through this procedure. Conceptually, the way I explain it to patients, it's like an orange. Well, we're going in and we're taking the meat out of the orange, but the orange is still there, the peeling. So that's basically what we're doing with that. So we've achieved great funding from the foundation for what's called a morcellator to grind the tissue up after this is done. And we have a new laser on the way, essentially, that will streamline this as well as part of the foundation funding. So thank you. Post-op care, just again for the nurses in the crowd, overnight stay typically with our outlet procedures, possibly same day with the plasma button. CBI, as you can imagine, is the foundation of this procedure. That's harped on a lot. I won't harp on it anymore, but that's obviously the foundation, and then the patients do a trial away the next day. So getting into the kidneys now, because we need to save some time here, I think. So kidney stones is a very prevalent condition. Everybody knows we do that a lot in the OR. These pictures here are literally just from this week of people's kidney stones that we treated, or that I treated. So it's a very prevalent condition. People are coming into our merge every day with this. It's extremely painful and causes a lot of agony and stress to the healthcare system and the patients, obviously. So the treatment options for kidney stones have advanced. The treatment options in principle are either they try and pass it on their own, they have ureteroscopy, which is our most common procedure by far for treating stones, or they have shockwave lithotripsy, or they have what's called a PERC, which is an invasive procedure that I'll explain a bit more in a second. So the two new things at Dartmouth, number one is the thulium laser. That has been absolutely game changer in the management of kidney stones in terms of efficiency, stones we can tackle, and just overall patient outcome, and I'll explain more about that in a second. And then the other big thing is shockwave. So shockwave is basically, in simplistic terms, where you send energy waves through the body, break the kidney stone up into small pieces that the patients can pass on their own. It was all done in Halifax, but now it's all done in Dartmouth as part of the redevelopment, essentially. So bringing more people, even more people through our doors. So the thulium laser, this is the picture here of the thulium. Again, lovely to be able to be funded for this by the foundation. And the biggest advantages for thulium as a laser technology is improved what we call dusting. When we treat kidney stones with the laser, there's two concepts of how you can treat the stone. One, fragmentation. Two, dusting. And the thoughts have changed on that over the years. A lot of people used to be, with the older technology, more fragmenters. You break the stone up into pieces and then go in with the basket and take the pieces out one at a time. It's time consuming, and it can be a lot of trauma going in and out of the urinary tract over and over. You grab a piece, you pull it down, it's too big, it won't come out, you have to push it back up, break it up smaller. So definitely in the past, I would say 5, even 10 years, even in they're part of my training, dusting has really kind of taken over in terms of treating kidney stones. With dusting, as you can imagine, you break the stone up into, I tell patients, like bits of sand, so that the stone just passes on its own, not with chunks. So the dusting with the thulium is a totally, it's 1,000 times better. There's minimal retropulsion. That means if you're sitting in the ureter, the stone's not flying away from you every time you hit it with a laser. It's, OR nurses will attest to this, it's way smaller than our old laser, footprint-wise, and it's really quiet. The old laser, it was like a 747 taking off. Like, it would just be humming in the OR, and it's very, very loud. And just simple things, like it can be used in any of the rooms, it can be plugged into any of the OR rooms, we can move around with it and stuff like that, versus the other laser needs special electricity. So this is a case here, this is one I just did a couple of days ago. So this is a lady with obviously a very large stone. Stones are white on this imaging, so you can see the stone's obvious. It's in the left kidney, taking up basically the whole lower part of the left kidney. Well, pre-thulium, and it's still an option for this lady, but pre-thulium, this patient for sure would have had a PERC, what we call a percutaneous nephrotomy. Patient would go in, all done at the BG. They go to sleep. It's a harder anesthetic because they have to be put asleep fully on their stomach, so that there's risks associated with that. And essentially, we bore a hole through their back into their kidney and break the stone up, grind up the pieces, suction them out, and they have a stent placed, and they're admitted overnight. They do go home the next day, and there's a fairly significant risk of bleeding, as you can imagine. Every heartbeat, 20% of the blood goes to the kidneys. So if you're boring a hole through a kidney, bluntly, then you can imagine there would be a risk of bleeding. It doesn't happen a lot, but it is there for sure. So that although it's an option for this patient, she wanted a more minimally invasive approach, and that's what we did. So she ended up having a flexible ureteroscopy. It's a day surgery, routine anesthetic, they're in normal positioning, and really minimal to no bleeding risk. In fact, I'll do these patients on full-blown anticoagulation without resuscitation. Yeah. So this is her procedure here. This is a stone, you can see it. Oh, there's nice. So this is a stone here, it's quite large. This is us going in, this is just an initial shot, getting a lay of the land, just some dye in the kidney. And then this is the ureteroscope up in the kidney, so it's like a flexible telescope basically. We can look in every little nook and cranny in the kidney, and then break the stone up into little bits of sand with a laser. And that whole stone probably took me maybe 45 minutes straight out on the pedal to break that up. They're different compositions. Her, fortunately, was fairly soft. They're either kind of soft, crystalline, or sometimes they're like diamonds, and you don't know until you get in there, but certainly with the thulium, it's been a game changer. And then this is just one slide. This is a shock machine, shockwave I was talking about. This is what we had in room 8, where patients come in, and their stones are targeted, and we send energy waves through. The other new kidney procedures, again, not new in general, but new to Dartmouth General, we've been doing our minimally invasive kidney surgery, so large tumors in the kidney, where the kidney's removed laparoscopically. And then a common one, especially more in my practice, is upper urinary cancers. So when you think of the kidney, there's two parts of the kidney. There's the meat of the kidney and the urinary part of the kidney. So kidney cancers are cancers in the meat of the kidney. So the tumor gets removed, either part of the tumor or the whole kidney. And then upper urinary cancers are really analogous to bladder cancer. They're the same kind of cancer, just in the upper part of the urinary system before it gets to the bladder. So the treatment for that is you have to take the kidney, but not only the kidney, you have to take the whole ureter, the tube, and the portion of the tube that inserts into the bladder. So post-op, routine laparoscopic kidney removal, that's usually a 1 to 2 day kind of stay, ideally 1 day. Mainly just pain control and getting the patients up and around. Whereas when we do the upper urinary cancers, we do an incision below the umbilicus, and they usually do end up staying a bit longer. It is more of an invasive surgery. They have drains, and just in terms of post-op stuff. So that's kind of a whirlwind through urology. Again, not all new procedures in general, but a lot of new stuff to Dartmouth General. We've had a full new department with John and I, new OR, new clinic, and entire new fleet of equipment in 3 to 4 years. So it's been a lot of changes for sure. And second part of our talk, just briefly here, touching base on the pelvic health suite. This is the new part of urology that's going to be a real game changer from an outpatient point of view. So this is, people have heard rumblings in the hospital, I'm sure, about this, and certainly seen it in the campaign ads. This is named Deanne Reeve Pelvic Health Suite, okay, in memory of this lovely lady. And what this is really a dedicated workspace for pelvic health, well, gynecologists and urologists. So this is going to be a dedicated workspace in the clinic to deal with all of the issues that arise within those surgical specialties. There's been a tremendous amount of fundraising. This became, a thought process a few years ago with Steve and Scott, myself, and some donors, and the traction that it has received in the hospital, outside the hospital, has been phenomenal. Over $1 million raised to support this suite and the equipment to go within it and help it run. And it's just been amazing. All the donors, the Orchid Gala, the J.W. Murphy Foundation, whose name clearly has come up several times here today, and Dorothy Gibson, Innovation Group for helping us get a business plan. And again, I can't thank enough people. Well, why? Why am I up here talking about this? Well, the wait time for, not just us, it's not just urology, it's not just gynecology, the wait list to see anybody is really long. And the one way to tackle it is just to put more people through. So if we have a space where we can see more people and have more throughput, well, we'll see more, we'll improve access to care for pelvic health, urologically and gynecologically. And in doing so, well, we do all that stuff in the hospital already, and it takes up space in other departments. So, we have a defined space. Dartmouth General is a defined building. As of now, we're going to expand, I know, but we're in a defined space, so we need to rejig things so that we can maximize the space that we're utilizing. Well, we had in the third part of the third hallway in the clinic sat vacant, and we jumped all over it, I guess. So that's basically the kind of concept. It will be there, well, gynecology will be there, urology will be there, and then a big component is pelvic floor physiotherapy. So pelvic floor physiotherapy is a rapidly expanding entity of pelvic health. Incontinence, chronic pelvic pain, prolapse, stress urinary incontinence, scrotal pain, chronic prostatitis. It's not just a female thing, it's a male and female thing. And access to it it's really hard. I mean, there's a couple of big pelvic health suites in the city and practitioners, which we send our patients. But as we're all aware, you need to have good insurance coverage to be going to these places. And a lot of our patients are great candidates. I offer them pelvic floor physiotherapy. I send them, they come back to see me and follow up, and they're like, I didn't have coverage, it cost X amount of money, I couldn't afford it, which I completely respect and understand. So the goal here will be to have those services in the building so that it'll be covered with healthcare essentially. So that's the ultimate goal and a very achievable one. Yeah. So here it is. It's this kind of a combination of my drawing on PowerPoint with some blueprints, but I'll kind of just walk you through it, and it'll be easier for those that are kind of familiar with the clinic just to know what the flow is like. Mouse is working. Okay, perfect. So this is basically the seating area right now. Big glass window back here. All the seats right here are outside of hallway 3. And basically, you'll come through the doors. It'll be obviously very well branded as a pelvic health area. There's not a lot of construction that needs to happen to change it over to a pelvic health suite. We're basically combining a couple of the rooms, rejigging some things to hold equipment, some monitors and stuff like that. So the overall structural changes are fairly minimal, which obviously help with cost and timeline, as you can imagine. But the overall flow of things, well, what is it? Well, it's one side of the hallway is going to be clinic space for pelvic health, and the other side of the hallway with all the colors here is essentially the endoscopic work area for pelvic health. Okay, so what will end up happening, I can't speak on Scott's behalf, but certainly on our gynecology behalf, but on urology, for males that come in for cystoscopy, it's a very streamlined approach. I mean, they come in, we don't change males for cysto anymore. They come into the cysto room, get prepared for their cysto, they get scoped, they get up, they go walk out the door, essentially. The biggest change for us is going to be having access to Uroflow, which we do not have now at the time of our scope. Uroflow, it's like a urologist at the scope, but you pee into a funnel. So that's essentially what it is, and that's where we get a lot of our information about urinary kinetics is from that test. The way it is now, for people, I had my scope day one day, I have a Uroflow clinic the other day. Well, it's 2 patient visits. Patients come for the scope, I think you need a flow, you better come back and have that done. Or they come for me for a consult flow, and then they need a scope, so they need to come back for another visit. So we're trying to combine 2 visits into one. Back and forth to the hospital for elderly frail patients is not easy, as you can imagine, especially when they live far away. So that would be the ideal goal. And this is pretty standard stuff, but we have to think of how to do it in our hospital. So just like I said, you come in through the door, there'll be a changing area. The next room coming down on the left-hand side will be the actual endoscopy room. So cystoscopy will be done there, and then your gynecologic procedures like hysteroscopy, storage workspace, and then the Uroflow will be at the end of the hallway. And then there'll be an entire clinic ideally going on the other side. So this should be used 5 days a week. And I'll have that coming up here in a second. So the current state of pelvic health at Dartmouth General, local cystoscopy is performed in the endoscopy suite. I scope at Dartmouth General a couple of days a month, 2-3 days a month, and in Coppicwood as well. So a lot of our patients go out to lower sacral for scopes. When this opens up, I'll probably exclusively scope all the patients in Dartmouth. We take up endo time. I mean, this is going to be open full days in endoscopy for GI scopes. So it's going to increase and improve access for GI scopes as well. Uroflow thing we already touched on. We're going to increase our clinic footprint, so a lot more urology clinic. Pelvic floor physiotherapy we talked about. And then there's all that ancillary urology stuff that happens in the outpatient clinic now, which is just, I call them sideshows. Like they're doing a BCG treatment in this hallway, a cath teaching down the hall. This will all be dedicated time. Nurses that do it every day in the pelvic health suite in one area versus a smattering of places. And then the gynecologic aspect as well. So volume is gonna increase. I mean, that's the whole point of the whole project. So urology, we have a 0.5 days each. Sean and I, a week there now. We'll go probably to 2 or 3 clinic days a week, 3 cysto days per week. We do about 90 scopes a month now at Dartmouth General only, and we'll be doing 65 to 70 a week. And it's needed. We have the patients for this. We have the wait list, so we'll have no problem filling this for sure. And dedicated space for the other stuff, like I said. And this pelvic floor physiotherapy. So the opening date, we're hoping for spring, summer 2024. Construction's been approved. They're probably going to hopefully get some work on the go. I talked to Steve about this the other day. In the next couple of weeks, and should be up and running 5 days a week with our 2 services. So it's kind of a whirlwind, I guess, of urology, but a lot of people to thank. A lot of people have been thanked already. The foundation for an amazing, just total overhaul of urology and men's health and women's health, not just men in urology, and at Dartmouth General. The innovation group have been profound help, especially with the business planning and getting the pelvic health floor up. All the nursing staff, perioperative nursing, pre-op, PACU, the OR nurses, all the nurses on the floor, the clinic nurses, endo nurses, and then our nurse practitioners, obviously, that help us as well. So, and then importantly, the donors are the ones that really kind of make it a reality, getting this stuff on the go. So, yeah, that's it. A lot new. I'm pretty proud of it, and happy to be a part of it for sure. Yeah. Any questions?
John, I said earlier to you that I was going to tell you this. Since you've come to Dartmouth General Hospital, I mean this in a very friendly way. You are like a fungus.
Yes.
You have spread into every nook and corner in the operating suite and in the clinic.
Yeah.
Congratulations.
Thank you. Exactly. So Steve wanted me to mention, so with the whole procedure, like I said briefly in the talk, we do have a new laser that's funded by the foundation, and it'll be the first east of Montreal, so that's going to help with that procedure that we just did yesterday. Well, not help, it'll revolutionize it, and ideally get that procedure being a day procedure as well. So again, just another big oomph for urology and patient care. Yeah.
I think this is the end of our session. I just want to thank everybody who came and everybody who's watching this by streaming. I want to thank the foundation for all their hard work and their donations, and the speakers. This was very entertaining, and learned things that I haven't seen when I was doing my training in surgery.